of this study and of this committee meeting, I would like to welcome everyone. The task that is being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of tasks can be found on the project website. We would like to thank our study sponsors for the support that they have provided for this very important work. The committee members are also listed on the screen. We will not have time to introduce each committee member today in order to save time to hear the valuable words for those who are joining us to share their stories and experiences, which is the most important perspective that we will have as a committee. I would like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that this committee has just gotten started. We have made no conclusions, and it would be a mistake for anyone to leave thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in order to get good information that will not be indicative of a personal view. We are also inviting residents, family members, and nursing home staff to submit their stories and experiences at the link provided on the screen. And I can assure you that every story and every word and every message that you send to us will be very carefully considered. We really want to hear your voice. Today's webinar will be recorded and archived at the link shown on the screen. I want to note that this is an open, on-the-record session. Individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor due to our time limitations. But please note again that anyone can submit testimony or materials to the committee at any time. And these documents will be placed in the committee's public access file. You can submit this information through the project website. The first very important session of our webinar today will explore family and consumer perspectives, the real stories. We have given each speaker a painful only 10 minutes for their remarks, and I know that's very hard to share what's so important to you. We will ask the speakers to be respectful of this time limit so that we have time for ample discussion with the committee members. I would like to now introduce the moderator of this session, Dr. Mary Ersick.
Thank you, Betty. I feel very privileged to be able to moderate this important session. And to that end, I'd like to introduce our 5 speakers. Kathy Bradley, founder and chief executive officer of Our Mother's Voice. Richard Mollett, executive director of the Long-Term Care Community Coalition. Lori Smetanka, executive director of the National Consumer Voice for Quality in Long-Term Care. Eric Carlson, directing attorney for Justice and Aging. And Beverly Laubert, state long-term care ombudsman, Ohio Department of Aging. And I'll turn it over now directly to Kathy, who will begin our presentation.
Good morning. Upon retiring after a 33-year career serving people with developmental disabilities in both institutional and community settings, I became the primary advocate for both my father-in-law and my mother, who had both suddenly declined into severe dementia in the preceding months. My father-in-law was able to remain in his home with supports, but my mother could not. Among her many remarkable accomplishments, she had been a lifelong activist for social justice for groups without a voice in our society. But dementia took her ability to speak, and she became a member of a group without a voice, nursing home residents who could not speak out when something isn't right. Armed with my experience, I became her voice. Today, you're getting the Cliff Notes version of our story. If you're interested, I do no-cost presentations on a variety of topics to empower and inform providers and advocates. Please reach out. Mama couldn't speak, but she was still herself, and she could communicate. Through her behavior, she let staff know her preferences in no uncertain terms. At least it was clear to me. But staff tried to medicate out of her all her efforts to let them know when she didn't like what was happening. You know the terms: combative, refusing medications, resistant to care, non-compliant, refusing meals, wandering, eloping. Never trained to view behavior as communication, staff saw Mama as needing to be controlled. They tied her in a wheelchair so she wouldn't wander and risk falling. Illness was misinterpreted as lethargy, so she ended up with repeated hospitalizations for urinary tract infections and dehydration. Ultimately, her out-of-control behavior, this 5'3", 100-pound, wheelchair-bound, fragile elderly woman, ended up with a psychiatric hospitalization with no legitimate mental health diagnosis. Staff needed to change the way they perceived not just my mother, but all residents. This is culture change, and it is not easy to accomplish. It starts with the leadership of the facility, and the leadership was, to put it graciously, not on board for some time. In fact, after working with staff, supervisors, the director of nursing, and the medical director without success, I approached the administrator at that time with my concerns, the second of the 4 I ultimately dealt with in the 5.5 years Mama was in the nursing home, only to be told, you need to be the daughter and let us be the caregivers. To which I responded, apparently you don't understand what it means to be the daughter in my family. I then went on to describe my mother's lineage, a long line of assertive women, and informed him that I was being the daughter. When I approached him on another occasion about staff not following the treatment plan from the psychiatric hospital, his response was, if you're not happy with your mother's care, we will help you find another placement for her. Well, having been a nursing home administrator for 23 years, I had never used that, which families view as a very thinly disguised threat. But I have heard it plenty of times, and I bristled at it every time. So I replied, no, you will not find another placement for her. You will meet her needs because that is what federal and state regulations say you are required to do. Even the CEO and board of trustees were not interested in hearing of the problems. Some said they flat out didn't believe me. I was considered a problem family member. So at that point, our family decided to take our concerns and my 30-plus pages of documentation of Mama's experiences to the agency responsible for the surveying for compliance with state and federal regulations. The agency used our documentation to inform their upcoming survey of the facility, and lo and behold, found the very same systemic issues we had identified in Mama's situation. The administrator was surprised, but culture change began to happen. For example, staff learned Mama's nonverbal communication. Walking up the hall means I want to visit my friends. Pulling away from staff means you're being too rough with me or you're moving too fast for me. Striking out means I don't like this situation. Lethargy means I don't feel well. Refusing medication means I don't know what this is or I don't like the way it tastes. Resisting getting up in the morning means, duh, I want to sleep longer. With this change, not just Mama's, but everyone's quality of life improved. Another example, Mama went from having urinary tract infections and dehydration every 6 weeks to experiencing 2.5 years of good health. The facility implemented a hydration program, and everyone's health improved. So even at her late stage of dementia, a culture of person-centered care mattered to her. When culture change like this occurs, it's almost magic. Staff are happier, residents are happier, work is easier, days are more enjoyable for everyone. Both staff and residents feel valued and empowered. Behavioral challenges decrease, and the use of psychotropic and sedating medications declines. Quality of life improves. Now, that's not to say that everything will be perfect, just a whole lot better than it was before for everybody. So how did we get this culture change in Mama's facility? Regulations. Without the power of the federal regulations, change would not have occurred. Quality of care, quality of life, and fundamental resident rights to a safe and dignified existence mean very little without regulations and strong enforcement. My experience with my mother and in my 33-year paid career are ample evidence that providers will not police themselves. Organizational culture tends toward staff convenience, not meeting the needs of each individual care consumer. That's just a fact. And if you need more evidence, just look at what providers of long-term care call themselves, an industry. Long-term care is not an industry. It is a caring profession, a profession of providing care for human beings. Regulations and strong enforcement are essential. The industry asserts that regulations are burdensome and enforcement is punitive, and that providers just need assistance and guidance and support. Newsflash, these regulations have been in effect since 1987. If they haven't got it by now, perhaps they need to reevaluate whether they're in the right business. They complain that fines are too expensive and they're losing money. But examination of the corporate bottom line, if one digs deep enough into the web of corporate ownership, belies that assertion. In fact, money is the only thing that speaks to anything calling itself an industry. Regulations lay the framework, and enforcement motivates when altruism doesn't. I provided long-term care services in the public not-for-profit arena for 33 years, and I know better. It's not the absence of money, it's how it's spent. As executive director of a county long-term care service agency, I had the same desk chair when I retired in 2009 that I had when I walked into my agency in 1992, and it was used then. I turned down a raise more than once and used the money to raise the wages for direct support staff. I spent the agency's money meeting consumer needs. Rather than lavishly appointing offices and facilities and protecting their bottom line, providers must focus on recruiting competent staff at every level, then providing them with sufficient and ongoing training to set them up to be competent at their jobs. And the jobs are hard. Then they must organize the work so that it's not chaotic when the nature of the job is chaotic. But it can't be seen as finishing a series of tasks and going home. It has to focus on meeting the needs of every individual every day. People are not widgets. Providers must ensure that competent supervision is present every day and that supervisors are actually overseeing the work and assuring staff competence every day on every shift. The administrator has to lead this effort and do it actively and visibly, not sit in the office or phone it in. Finally, external oversight, compliance, and enforcement are the only assurance we have that our vulnerable elders are cared for, which is all families want. I've been in this field for going on 46 years now, and I know I have lived these truths from provider and family experiences. I've been there. Thank you.
Thank you for those inspiring words. I also wanted just to point out a couple things first before moving to the next speaker. I failed to mention that the full bios for all our speakers are available in your briefing book. And also we'll be waiting until the end of all 5 presentations before we take questions from the committee. And so now we'll move on to Richard Mullet.
Hi, thanks very much. Thanks for inviting me. And Kathy, thanks for such a thoughtful and valuable presentation. Next slide, please. So a little bit about the Executive Director of Ulcers. We are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in long-term care facilities. We primarily do policy research and analysis as well as systems advocacy, but we do more and more public education, particularly over the past 10 years. I just want to say everything that we do and everything that I talk about here is predicated on federal data and of course the rules and the laws related to nursing home care. Next slide, please. So what I'm going to talk about is essentially 3 things. One, I want to talk a little bit about the foundations of nursing home care in the United States, which Kathy alluded to, and I think are just so important. And then I want to dispelling 2 biggest myths is that nursing homes are underpaid. And the second, which she talked about, is regarding regulation and the myth that nursing homes are overrun with some recommendations.
You seem to be cutting out a little bit. I would suggest turning your video off. We seem to have lost Mr. Malat. I'm going to suggest moving to Lori Smetanka, and we'll come back to you, Mr. Malat.
Great, thank you. Thank you so much for inviting me to speak with you today. The National Consumer Voice for Quality Long-Term Care was founded in 1975 as the National Citizens Coalition for Nursing Home Reform, or NCNR, because of concerns about widespread abuse, neglect, and rights violations that were occurring in nursing homes around the country. Since that time, the Consumer Voice has been advocating for quality care, quality of life, and protecting the rights of long-term care consumers. I had one presentation started for today and changed it because yesterday I was communicating with a nursing home resident that I've known for several years and started talking to her about how things were going for her during the pandemic. And she proceeded to tell me the following. More than half of the more than 80 residents of the nursing home that she lives in died since last April. She's not had a shower in more than 10 weeks. Bed baths were scheduled for twice weekly, but she often was not given a bed bath during that time. And actually, it's been more than a week since she had been bathed at all. She's had no restorative therapy for almost a year. She's frequently left in the same position for 8 to 10 hours every day. Her Thanksgiving dinner was cereal because the meal she was served was inedible, cold and ill-prepared. And another night for dinner, she was served a peanut butter sandwich, despite the fact that it's in her chart that she can't have that as a meal. For at least the last month, there's been one aide on her floor for 24 residents. And about half the staff in her facility have had COVID. Some have quit, others have been laid off, but definitely there's short staffing and there's no social worker. There's no activities. Residents have no one to talk to during the day. The staff rush in to perform a task and rush back out on to the next person. As troubling as this story is, the fundamental problems she raises are not unique to the pandemic, nor are they significantly different than what she shared with me before relating to insufficient staff, poor care, and low quality of life. While in some ways we've made good strides forward in caregiving, certainly I think we know what good care looks like, it's really disheartening that we've not yet achieved the promise of quality care and quality of life for not only this resident, but all residents that I believe exists in the Nursing Home Reform Act of 1987. As this committee gathers information and talks about the most pressing problems and looks to solutions, there are a few areas that require specific attention: addressing the need for sufficient staff, provider responsibility and accountability for meeting requirements, and the necessity of standards for owning and operating long-term care facilities, including accountability for the use of public funds. The number one issue that needs to be addressed in order to fully achieve quality in nursing homes is staffing. Study after study has shown the correlation between staffing and quality care, including having a minimum of 4.1 hours per resident day, yet most nursing homes continue to be understaffed. Most state standards are weak, and the federal requirement for sufficient staff continues to be vague and ambiguous. Almost all issues with poor and mediocre care, including the spread of COVID, occur because there are not enough well-trained staff available to address residents' needs. The pandemic visitation restrictions that have been in place since March of last year, I think, have shown the real dangers of not having enough staff available to provide care. It showed that, in fact, family members provide a significant amount of direct supports to residents that facilities and the staff have come to rely on, that include help with eating, hydration, hygiene, grooming, or calling attention to a resident's needs, such as if they have to go to the bathroom, need changing, or if there's a change in their condition. When family members were no longer available to provide this help, the staff, already spread thin before the pandemic, became even more burdened. Insufficient numbers of staff mean that care is not provided, shortcuts are used, and the risk of injury to the residents and the staff person increases. Ensuring that the staff have the training and support necessary to meet the needs of the residents living in the facility is also central to the provision of quality care. As the conditions and needs of residents have become more complex over time, staff often find themselves ill-equipped to address or respond to some of the care needs that are presented. Studies have also long shown the importance of having registered nurses on site and available to assess and respond to the needs of residents, as well as oversee the provision of care. That provision of care is higher and hospitalizations are lower with RN care on site. And studies have shown during the pandemic the positive difference in RN presence in responding to outbreaks as well as in resident outcomes. The COVID pandemic has highlighted the critical need for RN presence, for staff competency, and for the availability of direct care staff to implement and follow proper infection prevention and control procedures. But the training and competency in this area extends to all those working in a facility, including environmental staff, the housekeepers, the janitors, dietary, as well as administrative staff. They're all responsible for being trained and equipped to handle their jobs. As we think about staffing, we must also focus on what's necessary to support staff, to reduce turnover, and to attract new workers to the field. Poor working conditions, low wages, inadequate or no benefits are all factors in undermining the role of those on the front lines, caring directly for residents, and are primary factors in the instability of this workforce. High turnover rates plague this industry, not just of direct care workers, but also among facility administration. We hear a lot about the high turnover rates of direct care staff, but one resident recently shared with me that over the last year, her facility has had 4 administrators, 3 directors of nursing, 4 assistant directors of nursing, 3 staff development coordinators, and 2 social workers with no background in residential long-term care. It's incomprehensible to believe that consistent quality care can be provided with that much instability. Staffing definitely is a factor in the quality of care a resident receives. The ability of staff to know the residents they're caring for, their likes and dislikes, preferences in how they receive care, even nuances in how they look and act that might signal a change in their medical condition. But it's staffing that also directly impacts the resident's quality of life. Considering residents spend the most time with staff in the facility, it's reasonable to recognize that a resident's quality of life is directly related to the staff's capacity to engage and develop meaningful relationships with them. The importance of a person's quality of life and the impact on their overall well-being has never been more evident than during this pandemic. Isolation, separation from family and friends, lack of engagement from staff, all which have been common during the last 10 months, have resulted in significant decline in residents' physical abilities, cognitive abilities, and untold deaths. Families and ombudsmen and staff have shared with us numerous examples of residents who became depressed, anxious, and lost the will to live. We are regularly hearing from residents about the decline in engagement with staff during the pandemic, due in large part because the staff don't have time to talk with them as they run from one task to the next. The isolation has taken its toll. One geriatrician recently told me that he had at least as many patients living in nursing homes that have died from isolation as from COVID. There needs to be also greater accountability for nursing facilities to engage in quality assurance and performance improvement practices, evaluating its success in meeting standards, identifying areas of needed improvement, and establishing a plan for ensuring that those improvements are made. This process of ongoing self-evaluation and improvement should include direct care staff and residents to be part of the problem-solving process and to identify workable solutions to areas that need improvement. The quality assurance process, however, is separate from the regulatory oversight that's necessary for assessing compliance with standards and for protecting residents. Nursing home owners and operators must take responsibility for ensuring that they are meeting standards and providing the care and services necessary for residents' well-being as required under the law. Industry calls for a collaborative oversight process are misguided. Extensive supports and resources exist for technical assistance and training of nursing facilities and staff, much of it at low or no cost to the provider. It is not necessary nor appropriate that oversight agencies serve that role. I would assert instead that full enforcement of requirements of federal law is yet to be achieved. Underciting of deficiencies, multiple opportunities to appeal, undercoding of scope and severity, and low substantiation rates of complaints are all examples of an enforcement system that does not have the impact intended to deter noncompliance and encourage quick correction of problems. The range of remedies available, including bans on admission, use of temporary managers, and directed plans of correction, are also not used to their full potential. Enforcement has further been weakened by CMS policy changes from the last administration, such as the method for determining civil money penalties for past noncompliance. Enforcement action must be swift, fair, and impactful to make a real difference in facility practice and impact for residents. Weak enforcement efforts, poor and mediocre care has been tolerated for too long. Strong resident-focused enforcement action is necessary to prevent and address poor care. We will also be hard-pressed to fully achieve quality long-term care without addressing the increasingly problematic issues relating to ownership and accountability for decision-making and the use of federal funds. Increased standards are necessary for owning and operating nursing facilities. Currently, no meaningful criteria exist for determining approval of Medicare and Medicaid certification. Instead, CMS relies largely on state processes. Yet in many states, there is little to no evaluation of an entity's financial or management capacity to successfully operate these facilities and that they can provide quality care. At the same time, an increasing number of facilities are owned or operated by multi-facility or corporate structures, which has resulted in decreased staffing levels, reduced operating budgets, and lower quality of care. One example that our office received recently about a nursing home that was bought by a corporate entity last year resulted within days of the ownership transfer, the facility's budget being cut by 10%, staff laid off or told not to report to work, reducing the number of staff available on each shift, supplies being reduced, they're less available and of lower quality, and the quality of the food declined significantly. These corporations or multi-facility companies are establishing policies and practices for their facilities to follow. They determine the operating budget, they prescribe staffing levels, and they even tell facilities in some cases how much profit they're supposed to make. Yet they're not held responsible for the resulting impact, including poor care or harm to residents. Even during the pandemic, we have been told numerous times that corporations are establishing visitation policies that all their facilities must adhere to. Those policies, however, are not based on resident needs or rights, nor do they take into account the factors present in each facility and community. Accountability must also be required for the public money nursing homes owners and operators receive. The nursing home industry frequently complains that Medicaid reimbursement is insufficient to provide the necessary care and services to residents. We believe that greater transparency is needed with how current funds are spent, including through related party transactions, and that limits should be imposed on profit and administrative costs. Not only should there be better evaluation of the hundreds of billions of dollars currently going to nursing home and long-term care facilities, but we must also ensure that any consideration of new money into the system must be dedicated to resident care and supporting staff. One of the questions asked is whether more or less regulation is needed to achieve quality in long-term care. And I would say that regulations exist for a reason. Reports have shown widespread care and abuses that led the Institute of Medicine in its 1986 report to recommend a strong oversight and enforcement system. The law was passed to make changes. The first review and revision to the requirements of participation were issued in 2016. They've shown that these facilities, that CMS had solicited a major impact in making changes to the regulations and kept many of them intact and actually strengthened them. I think the better question we need to be asking is whether not more or less regulation is needed, which is an arbitrary question, but what the purpose of the regulation is and what it's intended to achieve and the best way to achieve that purpose. I'd like to close my remarks today with just a very quick story from a friend who's lived in a nursing home since the mid-1970s. This year will mark 45 years of living in a long-term care facility. She shared with us many times her experiences of conditions before the Nursing Home Reform Act and after, where she talked about rights violations and drugging and lack of input into how she lives her day. She will say that things have gotten better for her over the last several years from the Nursing Home Reform Act, but she still talks about the problems that she experiences on a regular basis and that residents in her facility experience on a regular basis, including the poor care, evictions, lack of services, and insufficient staff. So I would encourage this committee to be bold in its recommendations for achieving quality. We cannot accept the mediocre and poor care that is widespread in this industry. Thank you.
Thank you, Lori. And now we'll turn to Eric Carlson.
Thank you for the opportunity to speak to the committee today. Nursing facility quality deserves the careful attention that this committee can provide. I've represented the interests of nursing facility residents for almost 30 years. And let me start with the positive. I've seen some improvements over that time, consistent with what Lori just said, due to the federal regulations, the culture change movement, and competition from assisted living and other types of long-term services and supports. But as the committee knows, many or perhaps most nursing facility residents receive lower quality care. In representing residents, what has been most striking to me are the many situations in which facilities maintain policies or practices that violate the law and harm residents. Here are 4 common examples. First, and Lori and others mentioned this, failing to maintain sufficient nursing staff. In practice, this often means one CNA being responsible for an unmanageable number of residents. Because the federal law sets no fixed minimums for staffing levels, facilities rarely are cited until after residents have been harmed. And secondly, providing lesser care based on a resident's payment source. Payment source discrimination particularly visible when residents transition from Medicare to Medicaid coverage. During this transition, a resident's daily therapy often ends abruptly and completely, or the facility may attempt to force the resident to leave the facility entirely. More generally, this discrimination against Medicaid eligible people really, is shown in the common claims that Medicaid supposedly does not pay for the level of attention that the resident requires as a justification as to why the resident won't get what he or she needs. Thirdly, using antipsychotic medications for sedation. Kathy mentioned this. Despite an FDA black box warning, over 14% of facility residents receive antipsychotics despite having no psychiatric diagnosis, with catastrophic results from many residents. And then fourth and finally, and this is a broad category, obviously, failure to provide person-centered care. The federal regulations heavily emphasize a nursing facility's obligation to focus on the resident as the center of decision-making. Again, Kathy and Lori both spoke to this. In practice, however, most facilities act as if it's the resident's obligation to accommodate the facility's preferences and not the reverse. This type of systemic noncompliance may result in a deadening quality of life, loss of function, and physical harm. Any reform needs to change this reality. Among other things, the enforcement system should be strengthened to identify and sanction these harmful business practices, rather than waiting for a physical injury to assess remedies. By conditioning remedies on actual harm, the current enforcement system allows systemic problems to fester. I'd like to specifically address some questions from the committee. The first question asks for my perspective on the use of regulations and whether more or less regulations are needed. Based on my experiences, the federal regulations establish a strong foundation for high quality nursing facility care. The ongoing systemic problem is not that the regulations measure the wrong factors or inconsistent with current nursing practices. Instead, problems persist because, as just mentioned, nursing facilities are allowed to maintain improper business practices. The federal law is based on solid nursing expertise, specifically the IOM's 1986 report. And perhaps the central finding, the IOM recommended criteria based on whether facility residents actually receive needed services. The federal law is based on such results-focused criteria, along with a focus on person-centered care that was emphasized further in the 2016 regulatory revisions. Regarding the number of regulations, I respectfully here suggest that are there too many regulations is the wrong question, because it's too easy for facility operators or any other regulated entity for that matter to bemoan in the aggregate the number of regulations. Just say, oh, look at all these regulations. But if you advocate for fewer regulations, you should be able to point to specific regulations that allegedly are inappropriate or unnecessary. Assuming, as is true in this case, that the regulatory system is based on solid principles, you don't want a broad claim of too many regulations to justify a baby with the bathwater rejection of the entire system. Instead, reformers such as yourself should examine individual regulations to determine if any warrant elimination or reform. A couple comments about how the conversation goes in these matters. Whenever the value of regulations is discussed, provider representatives often present stories of facilities that have allegedly been cited for trivial or innocuous actions. I would suggest that those stories deserve little weight. They're generally anecdotal, and in any case involve violations that resulted in solely a deficiency. In a similar vein, I would encourage committee members to not uncritically accept talking points about a supposedly punitive regulatory system or of the value of a more collaborative system. Data show that the vast majority of deficiencies result in no remedy other than a plan of correction. Really, the current system is collaborative to a great extent, given the infrequent imposition of money penalties or other remedies, and the many resources made available through QIOs and other similar sources. To maintain the integrity and efficacy of the overall system, it's vital that survey agencies continue in their current role. Poor care must be cited, and when necessary, penalties imposed. Another question asks for perspective on the organization of resident care and the different types of nursing staff. I'll start here with what I think is a well-recognized fact. CNAs provide the bulk of direct care in a facility, but are underpaid and often divorced from decision-making processes. Improved pay and benefits are essential, quote a recent leading age report. Paying at least a living wage could benefit care recipients, workers, and communities, close quote. Also, CNA should be provided with a realistic career ladder and integrated with the care team. By giving CNAs more responsibility and influence, facilities can improve quality of care along with CNA's expertise in job satisfaction. And finally, I've been asked for what I think is the most important recommendation that the committee could make. Like Lori, I'll point to persistent short staffing, which is the precipitating factor behind many instances of poor care. You think about it: malnutrition, pressure ulcers, incontinence episodes, infections, lack of socialization. All of these problems often are attributable to a nurse aide being assigned to too many residents and not having enough time to truly attend to individual residents. Most recently, lower staffing levels have been found to correlate to facilities with greater COVID-19 problems. Thus, the committee could have the greatest impact by setting solid staffing minimums. The current requirements, among other things, requiring an annual facility assessment and daily disclosure of staffing levels, have proven to be inadequate. As a complement or alternative to staffing minimums, the committee could recommend a requirement that a facility devote a specified percentage of its revenue to direct care. One model is provided by recent New Jersey legislation that combines solid staffing requirements with an increase in Medicaid rates. That legislative package included mandatory minimum ratios for direct care staffing, an increased minimum wage for direct care staff members, and a revised Medicaid reimbursement rate with a requirement of the specified portion of the increase be devoted to direct care. Let's talk about money briefly. Historically, discussions about staffing standards are detoured inevitably into complaints about Medicaid reimbursement rates. But I would submit that discussions of rates really are compromised by nursing facilities' deceptively organized finances. The Byzantine webs of parent subsidiaries, management companies, landlords, real estate investment trusts, suppliers. These type of structures, I think, have zero clinical justification. They exist only to evade legal responsibility and conceal financial reality. And to my knowledge, there's no other business in the country that so routinely creates such complicated and deceptive operating structures. As we know, nursing facilities heavily rely upon government reimbursement, Medicare and Medicaid. Given that fact, it's inappropriate for them to disguise their profit and loss as they currently do. You just can't trust discussions about whether Medicaid rates are adequate or not, because you can't trust the data, the financial information from the facilities. The appropriateness of the Medicaid rates cannot accurately be evaluated unless and until these dishonest organizational structures are eliminated, which I think is fair given, again, the extensive reliance by nursing facilities upon Medicare and Medicaid reimbursement. So closing, I'll just re-emphasize the two primary points: staffing, adequate staffing levels, and secondly, not allowing improper business practices to continue and fester indefinitely. And again, I very much appreciate the opportunity to speak with the committee today.
Thank you, Eric. We're going to move on to Beverly Laubert, and then we will return to Richard's presentation, which hopefully will not be interrupted. So
Good
Beverly?
afternoon. Thank you. Thanks for the opportunity to provide input to your work. And thank you to Kathy and Lori for sharing those meaningful stories. These are stories that ombudsmen hear every day. I'll note up front that my remarks are presented in my role as the State Long-Term Care Ombudsman, as an independent advocate charged by the Older Americans Act to advocate for the interests of long-term care consumers, and are not necessarily the positions of the Ohio Department of Aging. The mission of my office is to advocate for excellence in long-term services and supports wherever consumers live. We believe that residents of nursing homes have the right to expect excellence. Requirements for participation in the Medicare and Medicaid programs are minimums. So our mission may sound lofty, but it is imperative that we raise the floor. Ombudsman work is all about the resident experience and helping to raise the voices of residents and encourage them to expect more. Let's remember that a nursing home for many residents is their home, and the people who work there work in a home. Residents do not live in the workplace of the staff. In terms of the most pressing problems, I'll focus on 4 key areas: who works in nursing homes and how they work, leadership, the environment of the home, and oversight. Residents must be able to count on clear staffing requirements, including 24-hour registered nurse staffing, an easy to understand standard for the number of certified nurse aides and dietary staff, and training that is aimed at providing not only general care and services, but also individualized care. Quality care is relationship-based. For example, a CNA, certified nursing assistant, is given education in the basic principles of dementia care. But to truly be equipped to support a resident with memory impairment, that CNA must know something about the resident's family and life story. Only then can the staff know and respond to the unique needs of the resident in their care. Similarly, the housekeeper should know something about the resident to understand that moving the resident's Bible into a drawer could be disruptive. When someone in maintenance is fixing a sink, knowing the resident was once a plumber allows for real human interaction. Current staff training requirements are insufficient to support residents' quality of living. The best practice that I've seen for such relationship-based care is consistent assignment of staff. We know that consistent assignment matters to both the quality of work life and the resident's living experience. Staff get to know specific residents, learn their preferences, and work proactively and efficiently. It makes the job more fulfilling. Residents and families don't have to repeatedly train staff on their preferences then. But until consistent assignment is required and enforced, not just recommended as a best practice, that it's the minimum practice, we won't see sustained quality care. One of the top complaints we receive in the Ombudsman Office is about not being treated with dignity and respect, a symptom of a deeper problem. The root causes are staff having too many residents to care for, they don't know the residents well, and are themselves not treated with respect. Current requirements include adding direct care staff to the care plan team. I was excited about that advancement when regulations were revised, but too often we hear that a nurse or a social worker has asked a CNA for input, but that CNA wasn't given time to actually sit down and participate in discussion at the care plan meeting, hearing what others say and providing feedback based on their hour-by-hour familiarity with the resident. They know more than they're given credit for. To achieve better care, a more robust workforce is demanded, and attracting the right people for this work requires respect, pay, and benefits commensurate with the significance of the work to the lives of older adults and people with disabilities. Generally, when we hear from residents about insufficient staffing, the focus is, as I just described, on the people they see the most. Additionally, I encourage you to make recommendations about sustainable leadership and disclosure of administrative history. When there is a change of operator or owner of a home, information should be available at about the quality of homes under the same owner or operator umbrella. In fact, there should be payer and regulatory scrutiny of that history before certification. The Affordable Care Act included provisions for nursing home transparency. We also were optimistic about that. The provisions were intended to make it easier to know who owns and operates nursing homes. Ownership information is posted on the CMS Care Compare website, but that is really just a start. Knowing who is accountable is still difficult, and consumers can't find performance history across multiple homes in one company. The turnover of administrators and directors of nursing you've heard about. It's especially problematic. We have worked with homes on quality innovation for months, only to lose ground when the leadership moves on. Administrators tell us that the owners won't give them the resources they need to meet even minimum requirements. Some states require administrators to report to their licensing board where they are working, but there does not seem to be a systematic way to analyze whether quality follows that administrator, or conversely, whether problems follow that administrator. Along the same lines, standards are needed for medical directors, their experience, how many facilities they direct, and the number of residents for whom they are also the attending physician. One area you asked us to address is the environment. While the prompt was about providing short-term and long-term care in the same setting, I'd like to continue focusing on the resident's experience. In some cases, the resident's goal is rehabilitation or short-term care and return home. In fact, we have heard that referring to them as patients is more in keeping with their goals. Many, however, need long-term care in a place they call home. Depending on the goal, we often see differences in the physical environment. Everyone should be able to have the choice of a private room, not just residents who might qualify for Medicare coverage of their stay, or people who are paying privately. We should all put ourselves in the place of residents and imagine what it would be like to live in half of a room with a stranger in the other half. Last evening, I was talking with a friend who's searching for the right college for her son. That 17-year-old gets more choice in who he lives with and the availability of preferred meals and access to enriching activity than an 80-year-old grandmother gets in a nursing home. Her home. And I will add, I'm not a scientist, but common sense tells me that if more residents lived in individual rooms, the spread of COVID-19 would have been more controlled. A second area of concern with the structure of some nursing homes is that locked unit. It might be called a secure unit, a behavior unit, a memory care unit, a dementia unit, or a specialized unit. No matter what it is called, I have seen few that are truly special. It is time for us to either fully integrate residents with varying needs or establish standards that involve more than a lock on a door. If such a unit exists for dementia care, staff must be thoroughly equipped to provide meaningful and evidence-based care for people living with dementia. The physical environment must be based on standards that are supportive of the individual. And antipsychotic medications should not be the default mode of care. My fourth major point is the regulatory system. In my state, one of the roles of my office is to assist residents with transition when facilities' failures of care result in termination of the facility from the Medicare and Medicaid programs. I have broken the news to hundreds of residents that they are losing their home. I have heard the angry family members who want someone to blame. After all, one move into a nursing home is hard enough, and having to help a parent, spouse, sibling, or adult child find another home to trust is even more difficult. They feel abandoned by the people who were supposed to protect them and support them. A widely underused remedy that could prevent this is temporary management. There should be a vetted directory of quality providers who are able and willing to be brought in to revive the performance of the facility without disrupting residents' lives. A few times in the closure process, we have been contacted by HUD when they are financing the building and don't want to lose the asset through closure. We've been told that they have the authority to require the provider to make changes. Earlier communication of performance problems in those cases might also prevent residents from losing their home. Collaboration across agencies should be formalized and sustained. The Special Focus Facility Program is in need of reform. CMS and the states select the most troublesome facilities for additional surveys to provide oversight. There is an artificial limit on the number of homes on the list in each state. We should re-examine who gets on the list and what level of scrutiny is provided, and establish an upper limit of how long a facility can stay on the list before a remedy like temporary management is imposed. Finally, we should be conducting satisfaction surveys to hear directly from residents about their experience. We use them in Ohio, and they can be effective tools for quality improvement. You've been given much to consider as you deliberate on recommendations, and I appreciate your interest in hearing from resident advocates. As Lori said, be bold. Residents deserve nothing less than a bold approach to improving their quality of life and quality of care. Thank you.
Thank you so much, Beverly. Let's return now to Richard Mullett, and I hope we can get his slides up there and his audio intact. Richard?
Great. Great, thank you, Mary. And thank you, and my apologies for, I don't know what happened, but I just disappeared. So I just wanted to, this is what I'm gonna be talking about, excuse me. One is, again, just the foundations of nursing home care, which some of my colleagues talked about, and then really focus on dispelling the two myths that we see as most problematic. One is that nursing homes are underpaid, and number two is that nursing homes are over-regulated. Excuse me. Next slide, please. And I would just say that, as I mentioned when I started the program before, we do policy research, we do a lot of data analysis. Everything that we do at the organization is predicated on the federal data, on performance data, on staffing data, on enforcement data, et cetera, and how those data comport or the finding or the conclusions one can make from those data, how they comport with the requirements of the nursing home reform law and the implementing regulations. So very quickly, and I think that, you know, my colleagues again touched on a lot of this, but I wanted to make clear for the committee how, and reconfirm for the committee how important the reform law is and what a important change it made in the lives of nursing home residents in the late 80s when it was passed, and of course, when the regulatory standards came out in the early 90s. So as others have mentioned, they've been in effect now for 30 years. And so none of this is new, none of the requirements are new, including infection control and prevention requirements, including the essential fundamental staffing requirements, et cetera. And as my colleagues have mentioned a number of times now, the law requires individualized resident-centered care, and it requires that all interactions with the resident, all care for the resident, all quality of life services for the resident are sufficient to attain and maintain that individual's highest practicable physical, emotional, and psychosocial well-being. Not practical in terms of what fits in with the financial model or the financial priorities of the provider, but rather what is practicable for that individual based upon where he or she is in life, what his or her goals are, et cetera. Lastly, I just want to say that participation in Medicaid and Medicare is entirely voluntary. If a nursing home operator does not wish to meet these standards, they are free to run their own private facility. Nobody is forced into participating in Medicare and or Medicaid. Next slide, please. So I wanted to make a couple of foundational points, which again, I think my colleagues have gotten at as well. One is that we have a right to the integrity of the use of public funds. And as Eric mentioned, most of the money that nursing homes get comes from either Medicaid or Medicare. We have a right to expect and to receive compliance with the minimum standards of care. Every resident deserves treatment that is both adequate and humane at a very minimum. And I think it's important to note that these requirements, albeit comprehensive, they really provide minimum standards. They're not overly prescriptive, and they really, again, are shaped one after the other. And we've read these numerous times, you know, the standards and the guidance amongst our colleagues, excuse me, is that they all really call for, again, focusing care, focusing services on the residents, which facilities under the federal requirements are only accepting if they can promise to provide those appropriate care and services. And lastly, American taxpayers deserve to get value for the money, for the, as Lori said, hundreds of billions of dollars that we are investing in this sector every single year. Next slide, please. So the problem is that, you know, federal data, our studies over the years, countless HHS Office of Inspector General and GAO reports over the years have indicated that these baseline tenets of what residents, what taxpayers have a right to expect are largely unrealized. Next slide. So myth number one, that the myth that nursing homes are underpaid. Next slide. So the myth is, this is what we hear from providers, as Eric and others said over and over again, that nursing homes claim that they don't get enough money to provide good care. And the reality is that most nursing homes in the United States are run as for-profit businesses and are continually seen as attractive investments by real estate investment trusts, by private equity, et cetera. So, and we're seeing both a growth in the for-profit percentage of ownership in nursing homes in this country, as well as growth of interest in and investment by private equity and the REITs, both of which I think pretty clearly belie the idea that nursing homes are money losers. Importantly, also, there are virtually no limitations on the use of the public monies. So nursing homes get Medicare, Medicaid monies. They can pretty much do whatever they want with it. And that's something that, again, my other colleagues have mentioned as well, is that we cannot have an honest discussion about profit and loss if we don't know truly what is being spent, where the money is going, and why. So this, as I note here, there's virtually no limits on the payment for administrative staff. There are no limits on the extent to which facilities can siphon off money into profits before putting a dime towards resident staffing or putting $1 towards food, et cetera. In addition, and this has been in the news many times now in recent years, starting with an excellent study by Kaiser Family Foundation, and that was reported in the New York Times about 2 years ago. Operators commonly use related party transactions to hide profits and to perpetuate the myth of so-called razor-thin margins. Next slide, please. So this is our fact sheet on Medicaid funding, that policy brief, that we put out about a week or so ago. As you can see here, and I put the link to it, just looking quickly at the chart, that's the revenue per patient day for Medicaid. What we hear over and over again, what I see repeated by provider newspapers and news outlets, and even by academics sometimes, is that the Medicaid payments are static, they're so low, et cetera. Again, as I mentioned before, we don't know. We have no ability to verify how low they are because the industry is very opaque with where those monies go. But here you can see that, in fact, since 2012, the revenues per patient day for Medicaid have increased. And as we note in the article, more financial accountability for facilities would decrease the likelihood of the nursing homes funneling cash to owners and investors at the expense of better resident care. Next slide, please. I want to talk a little bit about Medicare funding. As most of you probably know, Medicare pays much more than does Medicaid for resident care and services. Medicare people, as I think Beverly just noted, they don't often consider themselves to be residents. They see themselves more as patients. Medicare pays more for one reason. There's a number of underlying reasons, but one of them is that Medicare patients or residents are supposed to be getting significant therapy services, rehabilitation services, generally to get out of the nursing home and to be there for a short period of time. But as MedPAC has shown or found for, I think, close to 20 years now, that nursing homes on average have double-digit profits every year off of Medicare margins and of Medicare payments, and that these profit margins that I talked about here, they do not take into account profits that are hidden in administrative costs or related party transactions. So I think one thing that we need to be thinking about as a country, and I would urge the committee to be thinking about, is not only where is the money going, which is obviously the fundamental issue, but also how are we controlling the extent to which, how are we having any say in the extent to which monies that we pay to pay for care for a very vulnerable population, where that money is going. Next slide, please. This is, I think, the most profound, personally profound report that I've seen in my close to 20 years at the coalition. This is the Office of Inspector General report from 2014 called Adverse Events in Skilled Nursing Facilities, National Incidents Among Medicare Beneficiaries. And what the OIG found was that 1/3 of people who go into a nursing home for short-term Medicare rehab are harmed within an average of 15.5 days. And 59% of the injuries were preventable, or found to be preventable and attributable to poor care. As a result of that, 6% of those who were harmed died, and more than half were rehospitalized. And what this says to me, it's so chilling, but what it says to me is that even when profits are high, nursing homes fail to provide adequate care, safety, or treat residents humanely. Next slide, please. Myth number 2, that nursing homes are overregulated. I just want to point to some research here. Next slide. We did a report in 2015 looking at oversight among the states and how they compare nationwide. The one issue that I think I just want to quickly raise is that this really shocked me. We looked at citations for staffing, which, as my colleagues have said, there is a significant degree of understaffing across the country. About 75% of nursing homes, according to the data, don't provide 4.1 hours of care staff, which the 2001 Apt Associates study found is really what's needed to just meet clinical care needs. But what we found here, and again, I thought one of the most, the biggest takeaways for me was that when it comes to pressure ulcers, which according to the professional standards and according to the CDC are almost always preventable and or treatable, even when states do cite a facility for inadequate pressure ulcer care or prevention, they only identify this as harmful to residents about 25% of the time. And it's just, I'm not a clinician, but it's incredibly striking to me that when you have identified, when even the surveys, which Eric and others have said, generally don't do a great job, frankly, in identifying and citing facilities for problems, but even when they cite for that the facilities' poor care resulted in a wound, they only identify that as causing harm to a resident about 25% of the time. I'm just going to quickly read the headings in the next couple of slides. So if you can just move quickly, please, so I can finish up in time. Next slide. Oh, so I'm sorry. Here, GAO better. The GAO has done a study. The better oversight needed to protect residents from abuse. Next slide. OIG, incidents of potential abuse and neglect at skilled nursing facilities were not always reported and investigated. OIG, trends and deficiencies at nursing homes show that improvements are needed to ensure the health and safety of residents. OIG, again, CMS guidance to state survey agencies on verifying correction of deficiencies needs to be improved to help ensure the health and safety of nursing home residents. And lastly, this was a study that just came out last May. GAO found that infection control deficiencies were widespread and persistent in nursing homes prior to the COVID-19 pandemic. This is only a selection of those studies and only one of the studies that we've conducted over the years. But study after study has shown that, as my colleagues are saying, the promise of the reform law, the promise of those basic standards of care are too often not realized for our residents. Next slide. So in sum, we do not get value for the money that we as Americans spend on nursing home care. I would say that overcredulity of the nursing home industry's arguments have served neither residents nor taxpayers very well, and that perpetuation of the industry's myths has been particularly costly for residents and their families, as Kathy and Beverly and Lori in particular talked about before. Next slide. So I'm going to quickly just go through the orange headings here. These are some of the recommendations, some baseline recommendations that we put together. One is that we need to have meaningful accountability when facilities fail to provide adequate and humane care, including really meaningful oversight, quality assurance, and enforcement. Next slide. We need to improve accountability for the use of public funds allocated for resident care. Next slide. And we need more transparency and accountability for nursing home ownership and management. Next slide. Lastly, as my colleagues have mentioned, steps must be taken to ensure sufficient staffing to at least meet minimum standards of clinical care. Next slide. So thank you very much. I apologize for the snafu before and appreciate the opportunity to present.
Thank you. Thank you all for your thoughtful and thought-provoking presentations. We're now going to open it up to questions. This will be open for the committee members only, as Tracy noted earlier, although we invite other people's questions and comments via the website. I'm going to ask my colleagues on the committee to raise their hands, so to speak, via Zoom, and see if anybody has any questions. I would like to start while we're waiting, because I don't see any hands quite yet. I'd like to ask the speakers. The other thing I wanted to mention is we only have less than a half hour. And so I would invite a couple of responses to each question, but to address each of the committee's questions, I may, move on to the next question before we have an opportunity to exhaust the discussion on the one question. I did want to ask, though, several of you talked about certified nursing assistants, who are near and dear to my heart. That's how I started in nursing homes. And you talked about some ways that we can retain and honor what they do. We can pay them more. We can give them clinical ladders. But how do we attract really excellent frontline staff? And those might be, nursing assistants, but as well as other people who want to work within that community of the nursing home, particularly giving direct care or interacting directly. How do we attract them to long-term care? Anybody have any ideas?
I think wages are, I'm sorry,
Yeah,
Richard.
go ahead, Kathy.
I think, thank you. I think wages are, an obvious answer to that question. If it's attractive pay, then it's going to attract people to work there. But in my experience, training and competent supervision and support are extremely important to helping people become competent, keeping them competent, and supporting them in doing their job. Without those things, quality will begin to trend downward, even if you're paying people well. If you're not providing them with training to be competent, with supervision to assure that they're doing what they're supposed to do, and with the support that they need to do their jobs well, care is going to decline.
Thank you.
This is Richard. I would just piggyback on that because I agree. We did a study when I first started on working conditions, and that was the major complaint from every level of care staff was that the CNAs felt completely disrespected by the LPNs felt disrespected by the nurses, and the nurses felt disrespected by the administrative staff. And I would say just to everything that Kathy says is right. And the point I wanted to really add is that it's not that nursing homes can't find staff, it's that nursing homes eat up staff. And that does, of course, make it more difficult to find staff to begin with because they developed a reputation for being poor places to work. But people, I know that a nurses association in my state, I'm from New York, did a study many years ago, and they found that the staff are there in New York State, the nurses in particular, they just don't want to work in long-term care because they have many of them, and they got out of it because it was just such a hideous and demoralizing experience.
Yeah,
Right.
that's
Thank
right.
you.
It's a lot about the reputation of long-term care. I know people who, graduate, dietitians, nurses, and so on, and say, we really need good people in long-term care. And they say, no, why would I ever want to work there? That would be a career suicide is the term I've heard, if you get a reputation of working in long-term care. So we have to raise quality, and we have to improve the reputation of high quality facilities, and talking about older adults, personalizing it. You're caring for someone's life.
And so
Thank
many
you.
of the people, I think, really are interested in developing relationships with the residents that they're taking care of. They become like family members to each other. They need to be supported and involved in the decision-making that occurs within the facility, and involved in problem-solving practices and in quality assurance programs, and feeling like their voice makes a difference, not just that they're there to perform tasks. So that if they're supported, as well as the other things that my colleagues have said, support for funding support and wages and benefits, but working conditions, consistent assignment, putting all of the things that we know make a difference. We know these things, putting them into place, I think will attract people to the field.
Thank you. I want to, I see that I've got four hands up. And so I'd like to thank you so much for those responses, those very thoughtful responses. But I'm going to switch gears here to make sure that we have an opportunity to let other people ask questions. I'm going to call on David Stevenson first.
So Mary, I'm going to actually let Kathy Greenlee go first, because I saw her chat comment first, then I'll go second.
All right, I was going to call on her next, but go ahead, Kathy.
Thank you, David. I'm not able to find my raise hand feature today. So I have just a general question for any of the panelists. Thank you all for participating today. I wonder if you have recommendations for us with regard to the state survey process itself, not the regulations, but the effectiveness or ineffectiveness, or just advice on state survey units.
Consistency. I just this morning did a presentation for new surveyors in Ohio and talked with them about resident quality of life and focusing on residents being open, thorough investigations. I don't know that we see consistency. I've heard this from my colleagues in other states as well. Or providers even in other states, when a surveyor shows up, that they, it's not a big deal, it'll be fine, but they tell me that there are definite deficiencies in the facility that surveyors don't find.
I would also say training for surveyors is really critically important. Some of the training that surveyors are receiving are just based on online videos right now. And it seems that they're responsible for such a wide range of issues that they're surveying for, that there needs to be very good training around not just the issues that they're surveying for, but investigations. They need to be trained related to that, and also to have the range of expertise available to the survey agency, like financial accountants, for example, and legal support, and other issues that you don't, when you have most of the surveyors with nursing backgrounds, their expertise isn't in the broad range of issues that they're looking for. So they need access to those wider ranges of people. And then the last thing I would say is survey agencies also are exceptionally underfunded and under-resourced. And so we really need to look at providing better supports for those agencies in order to do their work.
In that same vein, I just think that the survey process may have to dig a little bit deeper. I think as a practical matter, surveyors are likely to cite things that are visible to them in their face while in the facility. But I think some of the problems that we talk about here don't necessarily reveal themselves when you're walking down the hall or just opening up someone's chart. I think if you know anything about the nursing facility industry, you know they're likely there, but it's going to take a little more affirmative digging by a surveyor to identify those things, rather than waiting for harm, for example. And when you wait for harm, obviously the problem is the harm's already occurred.
This is Richard. If I could just quickly add, the CMS revised the requirements for survey in 2017, and that's been in effect now, of course, for just a little over 2 years. And I think it's overall really good. That the issue is still the disconnect between its implementation in the survey and how the surveyors, are using those requirements and how they are empowered to do so. And that's a real issue that we see. I mean, I think there's, as one funder said to me a couple of years ago, about the agencies being co-opted. And I think that's too much of what we see, is that the agencies feel co-opted. The surveyors are made to feel like they have to be Perry Mason in order to prove beyond the reasonable doubt. And we've seen, now that we have more and better data available the last several years, of situations where I've seen the exact same cases that are not substantiated by a surveyor, that are a Medicaid fraud control unit is able to hold the provider criminally accountable, which is really in our country the highest level and the hardest thing to prove. How come they can do that, but the state surveyor is not able to do that? So just, again, I think like with the rules, the basic structure is there. It's just not being utilized in an appropriate way.
One other thing that we've seen is the inability or hesitancy, I'm not sure what it is, of surveyors to look at things like hospital records or interview someone at the hospital. A hospital might be the one reporting someone who has gone there and has multiple wounds that the facility had not been treating. So surveyors have to have access to those hospital records and the staff to be able to support their investigation.
I'm going to thank you. I'm going to move on to David's question now.
Yeah, first, thanks very much for all of your comments. These are really helpful to hear. So a couple of related questions to the oversight process. The first is, I heard several of you talk about kind of keeping the consultative services, the QI related things separate from oversight. But I didn't hear any of you speak about potentially targeting survey activities to a greater extent, surveying lower quality facilities more intensively, like the Special Focus Facilities Program, and higher quality facilities at any lesser rate, either in terms of visiting them less often or doing targeted surveys. So I'd like to hear on that piece, if I could. And then the second piece is, some of you spoke about enforcement mechanisms beyond civil monetary penalties. And I'd like to hear thoughts on kind of other mechanisms that you think are underused in enforcement. Thanks.
This is Richard. I mean, we've done, if I may, I think that the states already have a lot of wiggle room in which to more frequently survey facilities that are problem facilities. I think that the whole, and our general recommendation now is that the whole paradigm should be shifted from 9 to 15-month window to really a 6 to 12-month window, because at least, you really need to have at least once a year of someone going into the facility and really investigating, talking to residents, talking to staff, talking to families, and talking to ombudsmen, as they are required to do under those the protocols that CMS promulgated 2 years ago. That needs to happen at least on an annual basis. And as you're talking, I'm thinking about what Kathy said in her presentation, that she worked with, was it 4 different administrators in a 2.5-year period? There is a lot of turnover in the sector, and business, not only just turnover among staff and administration, but changes in ownership, et cetera. The state needs to be in there on a minimum, again, of an annual basis. And I would say, what we do in the Special Focus Facility Program is, as you may know, is that it's biannual, that the state agency is supposed to be in there on a biannual basis. I think, again, the Special Focus Facility Program laid out, at least on paper, a good way of getting at poorly performing facilities. Unfortunately, it hasn't been very well implemented.
Two points that I think this is around the same line of what Richard just said on the survey frequency. More frequent surveys are fine, but not making surveys less frequently for a different tranche of facilities. I think we would say that the current 1-year range is a minimum, and more frequent. You shouldn't have to trade more intense surveying of certain facilities for less frequent surveys of other facilities, because actually every year actually isn't that frequent. A lot can happen in 365 days. And then as far as remedies go, I just point to one situation. Our frequent complaint is that facilities sometimes are found in violation and they don't even fix the problem for that particular resident. I think particularly if you talk about return to the facility sort of situations, facilities are cited, and they were still refused to take the person back. And so whether that's a directed plan of correction or a per diem that's fine, that's definitely tied to actually fixing the existing problem is needed, because we do see these cynical situations where violations are noted and the supposed correction doesn't even remedy the situation for the resident who's been hurt.
Right. We hear often facilities say, that's okay, I'll take the fine. I'll take whatever the penalty is. I'm not taking that resident back. So discharge is the top complaint ombudsmen receive year after year after year. Eviction from their homes, thousands of them every year.
And I think when you look at the facilities with significant problems, yo-yo compliance, I mean, we should not be allowing those facilities to admit new residents. If they can't adequately care for the people that are currently living there and they're not making the corrections necessary to adequately care for them, they should not be letting new people in. It just perpetuates the harm, and it just perpetuates the poor care that's being established. And, you know, we have asked states and CMS over the years about why temporary management isn't used more frequently, for example. And every time when we ask the state particularly about it, they don't have a process in place for identifying who they would put in as a temporary manager. They've not established and set up a system. So they'll often say, we don't know who to put in, where you would think that if that was one of the remedies that was available, they should have a plan for how they would use it and when it's appropriate to use it. Because you know, the alternative in many of the situations is that they're looking for decertification of the nursing home, which ultimately then can lead to closure. Why should the residents have to leave when the problem is the administration or the owners? We should look to fix that problem, not make residents leave from their homes.
And if you look at the guidelines, temporary management is the remedy for immediate jeopardy citations, but it's still not being used.
Thank you. Let's move on to Jasmine's question. Jasmine Travers.
Thank you, Mary, and just thank you for the panel for your thoughtful insights. Richard Mallett and Eric Carlson, along with others, made references to the myths around the underfunding of nursing homes. Richard Mallett presented very recent data of the rise of Medicaid funding over the past decade. I question, are those increased rates enough, especially when we see nursing homes with greater proportions of Medicaid residents still reporting poor care quality? And then if it's possible that nursing homes are adequately funded, but just not putting money where it needs to go, how do we discern these nursing homes? Is it best to think about requiring that a certain amount of reimbursement is allocated to important areas to resident care, such as staffing?
Yes. So in a nutshell, you know, as I mentioned briefly, really two things should be happening here. One is that we need to have better transparency and accounting for where the public money goes. Because right now it's honestly a black hole. Nursing homes can do whatever they want with that money. Lori talked before about a resident who had cereal for Christmas dinner. I heard time and time again over the years of nursing homes that put in like $2 a day into food for each resident. Of course, you know, as we've all said, the staffing, and as you know, numerous again studies have shown, staffing in most nursing homes is inadequate to even meet basic clinical needs, no matter quality of life, treatment with dignity, and humane care. So money is not put into staffing because nursing homes don't have to. So one, we need the transparency, and two, we need to make sure that if someone is signing up, again, this is entirely a voluntary process. You don't have to participate in Medicare or Medicaid, but if you're doing that, that you have to promise to put at least say 90% of the money that you get into resident care cost centers.
I'll just say, I think this is maybe the biggest problem, one of the biggest problems, certainly in these public policy discussions, because in practice, I think that the facilities and the surveyors pay less attention to the regulations. people will say, well, look, person-centered care is required and there can't be any payment source discrimination. And you got to give people the care that they need to get to the highest practicable. And people say, well, yeah, but just given the money, we don't really expect that. So because of this belief that the money is not enough, then the requirements of the regulations are disregarded or not really taken seriously. And there has to be some grand bargain where everybody says, okay, this money is enough, right? No more complaints. This is enough money. We're serious about these regulations, and we're gonna make it happen. And whether that's requirements that the minimum amount of money go directly to staff to make sure it's devoted. But I think also, as I mentioned, there has to be some clarity about finances so we can come to some consensus about and be able to say, and the industry people can agree, yeah, this is enough money. This is enough money. We're, like Richard said, it's a voluntary program. We're signing up voluntarily for this, and we recognize that accepting this money means that that we're going to be bound by these requirements. And we need the level of transparency regarding facility finances, some consensus that the reimbursement is adequate, and then the willingness to take the requirements seriously and enforce them.
Thank you. I'm going to turn now to David Grabowski for the last question of the session.
Thanks, Mary, and thanks to all of the speakers today. Really powerful remarks, and really appreciated everyone's presentations. Jasmine really set up my question nicely. I've been thinking a lot about this issue of transparency, and many of the speakers today talked about greater transparency in ownership with related party transactions and REITs and private equity investment, but also greater transparency, as Eric was just describing, with where the dollars are going. And this is something that I think I feel really strongly about. I'd love to hear ideas that any of the speakers have today on how we do that. We've talked in the past about greater auditing of cost reports, for example. Are there ideas that you have about how we could both? We were supposed to get, for example, greater transparency and ownership with PAYCOs. I don't think that's happened to the degree any of us would like. Any thoughts on how we improve transparency with ownership and how we improve transparency in terms of financial transactions? Thanks.
I'm going to say that in preparing for this, I started thinking about just barring certain forms of organization as opposed to transparency requirements, because it feels like transparency requirements are just setting us up for continued frustration. It's so complicated. We know this, right? Given the investment trusts and the various management entities, why is that? And I think it's legitimate to say to the providers, if you're going to accept federal money and state money, you're going to be heavily reliant upon that, and you expect reimbursement rates to be accurately based upon your costs, you're not going to be allowed to set up your businesses in such a way, because it frustrates our ability to come up with a system that makes sense. So that's where I'm heading in thinking about this presentation today. That it's a fool's errand to talk about transparency. It's a nightmare, and there's reasons why some of these requirements aren't implemented, or even why they are. They're not effective. You could save a lot of grief by just prohibiting those sort of evasive organizational structures to begin with.
This is Richard. I mean, I think that I agree with Eric to a large extent, but I think, and I'm not, I don't know if I can't say what he's exactly saying, of course, but I think that transparency is still important. I mean, we do, as you know, David, get cost reports. They are very complex, but there are states that do better jobs at providing information, summary information, et cetera. I mean, California, there've been websites that have done really good jobs, a really good job, I should say, in providing information about ownership, about paying, not so much, well, ownership, excuse me, the money, how much staff are being paid, who provide care in the facility, et cetera, so that we can have more transparency. And I do think that we need that, but I also agree with Eric that we need to also be shaping who should be owning this. I mean, what really has struck me over the past several years is how incredibly sophisticated the industry has become, and that we have not kept up with that as an enforcement system, or even as you were saying, even in our ability to track. So the ACA, in 2010 required 5% ownership interest, but where does that really get us with limited liability companies, and then the related party transactions and the REITs, et cetera, owning underlying properties and providing management services, et cetera, et cetera. So I think it is very complicated. It's not a panacea, but I do think that it's important. We're putting money in. Where did that money go? And maybe having some way of tracking, I'm sorry, just lastly, having some way of tracking whether, the appropriateness of spending. I mean, we all, those of us who work in academia or nonprofits know you have to show what your expenses are and that they're reasonable within a community, but nursing homes currently don't have to do that. So they can charge themselves, a related party, whatever they want in rent, and then turn around and say, oh, we don't get enough money. I'm not even making my rent. Yeah, you're not, because you sold your property to yourself, and which this commonly happens. And now you're paying yourself 5 times the market rate. You can do that.
I just thank you. Those were great comments. Betty, I'm not sure. I thought the session ended at 1:35. We do have one additional question that I wasn't aware of because we're having difficulty with the hands raised. Do we have time for one more question from Colleen? Tracy, is that what? Yeah.
It'll be a short one. It's actually directed to Lori Schmatenka. I want to thank the panelists for all of their enlightening presentations and comments. But Lori, I want to commend you for recognizing the need for qualified holistic care that moves beyond nursing care and incorporates social, environmental, and dietary factors. Here's my question. When thinking about the social care and psychosocial care needs of residents, what are the types of staff needed to address those needs? For instance, in your opinion, are activity staff, social workers, and social service staff important to have on board in facilities in order to address these aspects of care?
Thanks for your question. Activity staff, social workers, they're critically important, along with the CNAs and the nurses. It's the activities professionals and the social workers who often are the ones helping make connections with members of the community, keeping people engaged in activities, keeping them engaged in things that are happening within the facility as well as in the surrounding areas. We have actually had a good relationship with a provider a few years ago who, in his efforts to reduce the use of antipsychotic drugs in his facility and to provide better care to the residents, particularly those with dementia in his facility, he really invested in activities people and had a really robust set of activities that were available for the residents at all cognitive levels so that they could continue to be engaged, and their needs for interacting with people, for human contact, for feeling fulfilled in their day continued to be maintained. And so they're very critical. And we can't forget that residents are also interacting with dietary staff. They're interacting with housekeepers. They're interacting with janitors. And they also need to be trained not only on their own jobs and, frankly, infection control practices, because I think in this pandemic, that's another area where, we need to beef up that training, but also, how best to interact with people and to allow them to be engaged with the residents as well. It's a community, and that's what we need to be looking at the nursing home as, a community of people that are there to support each other.
Thank you
Thanks
so
very
much.
for those comments,
I
Lori.
think we already know that we could go on, for a very long time on all of these important questions. We thank you for your passion. Also really want to thank the entire panel, because I think what you've done already today is to remind us of the real quality of life issues for residents on an everyday basis in these homes. And also to remind us of the complexity that we have to consider, all of the elements if we really are going to improve the quality of nursing home care in America. We really appreciate all of your input. So thank you, Dr. Ersick, and to all of our panelists. We're going to move into our next session, and the next session will focus on clinical perspectives. The moderator for this panel will be Dr. Jasmine Travers, and I will turn it over to Dr. Travers to introduce the panel.
Thank you, Dr. Farrell. It is my pleasure to have the opportunity to moderate another esteemed panel, this one representing the clinical perspective, and includes Amy Stewart, Vice President of the Education and Certification Strategy at the American Association of Post-Acute Care Nursing, Faith Wiggins, the Director of 1199 Service Employees International Union Funds, Home Care Industry Education, Dr. David Nace, the President of the Society for Post-Acute and Long-Term Care Medicine, also joined by Dr. Carl Steinberg, the President-elect of the Society for Post-Acute and Long-Term Care Medicine. And lastly, Dr. Kezia Scales, Director of Policy Research at PHI. Full bios, again, for these speakers can be found in the briefing book for the webinar. And with that, I will turn it over to Amy to get us started. And just one thing, again, we will hold our questions until the end of all of the speakers. Thank you, Amy.
Thank you, Jasmine. Thank you for inviting me to speak today to represent the voice of nurses in post-acute and long-term care settings. I applaud the work of this committee, and I'm honored to support your discussions. As Jasmine said, my name is Amy Stewart. I'm a master's prepared registered nurse with almost 25 years of long-term care experience in nursing homes. I've worked my entire career there. I'm currently the Vice President of Education and Certification Strategy for the American Association of Post-Acute Care Nursing. Today we'll call it a PACN for short. And a PACN represents over 18,000 long-term care nurses, primarily in two roles: the Director of Nursing and the Nurse Assessment Coordinator, responsible for the completion of the minimum data set as well as the care plan. A PACN's mission is to support the professional development, empowerment, and success of members through resources. I'm honored to present to this workshop to highlight our members for their dedicated public service in caring for the most frail and vulnerable in our population. The role of nurses in post-acute and long-term care is a daily struggle to gain both respect and adequate resources. Even prior to COVID-19 pandemic, our members and skilled nursing facilities across the country faced a crisis in staff retention and recruitment caused by low pay and lower regard for their services. COVID-19 has only exacerbated this challenge. While I fear that the outcome of our healthcare sector's COVID-19 experience will be an increase in punitive regulations, I can assure you that more regulations will not help if we cannot attract and train a new generation of skilled nursing staff. As such, I have 4 recommendations for the committee's consideration. You're going to notice a theme similar to the first group of speakers. First of all, my overarching recommendation is that the committee spearhead research between the negative stigma of working in a nursing home and its impact on recruiting talented CNAs and nurses, and how to better address and resolve this issue. The nurses who work in post-acute long-term care facilities are not highly regarded by their peers in other healthcare settings, nor by the public. Post-acute long-term care nurses are often seen as inadequate, when in truth, they function autonomously, without a physician only a mere feet away, like you see in acute care. The certified nurse aide experience is similar. They are often belittled, disrespected, with wages much lower than comparable roles in other care settings, and often lower than fast food restaurants offering minimum wage positions. Stigmas against the nursing home setting hinder a facility's ability to hire staff, especially students who believe working in this environment is less prestigious than working in acute care. This in turn leads to lower quality of care for those we serve. One study has shown that with each 1-year increase in the director of nursing tenure, it can result in a 10% higher likelihood that the facility will demonstrate a 5 out of 5 quality measure rating. In order for us to attract and retain the director of nursing, we must be intentional in our endeavors and seek ways to elevate the status of the long-term care nurses and CNAs so that they are attracted to this sector of healthcare and know that taking care of the elderly and frail in our society is honorable and meaningful work. I'm afraid that unless we address this demeaning stigma, even with staffing mandates, additional regulations, and additional funding, we will still fall short. My second recommendation is to ensure that professional development opportunities and the development of collaborative models for post-acute long-term care staff. We improve quality of care by providing nurses the professional development opportunities they need to advance their knowledge of gerontological nursing, particularly the registered nurse. The medical complexity of those receiving care is increasing. RNs should be recognized and utilized as the expert gerontological nurse through research that can translate into real-world application in this complex long-term care environment with the results of improved outcomes. We also need a better understanding of effective collaborative models between the RN and LPN, as such models can improve the quality of care by using these professionals interchangeably. Post-acute long-term care providers are often hard-pressed, especially in rural areas, to find RNs and rely solely or more heavily on LPNs in the role that an RN is better equipped for. My third recommendation would be that we support leadership development among nurse managers as clinical team leads. Several research studies have linked engagement with retention. Clinical team engagement is critical to post-acute long-term care because the discretionary effort given by engaged employees directly impacts a resident's quality of life and improves staff retention. This goes beyond a leadership training course. RNs in long-term care settings are not just regulatory compliance managers, but they're an integral part to the team engagement, and they are equally as important in clinical outcomes. In the APACN 2019 DNS work study, we noted that 54% of the directors of nursing had an associate's degree, and these programs, while valuable, offer fewer courses on leadership. Strengthening the leadership skills will improve quality and better equip nurses, especially during challenging times like we're seeing today. And finally, we need funding to support technology to streamline processes so nurses can spend their time at the bedside assessing and caring for patients. Acute care settings have benefited from government funding to support the implementation of electronic health records. Hospitals are able to automate various reporting and quality data abstraction that provide them with information they need to guide their improvement efforts. Nurses working in post-acute long-term care are often relegated to manual abstraction of data because they do not have the resources of automation. The time a nurse spends doing this is taken from patient care and is a waste of resources. There are many technological advances being made that could improve quality of care and support the work of nurses and CNAs alike. But access to such technologies is often cost prohibitive and only seen in acute care settings. The use of technologies is not well researched in post-acute long-term care either. Studying the use of technology by post-acute long-term care nurses and CNAs with real-world application to practices would translate into improved care. I thank you today for the opportunity to speak on behalf of APACN's members and nursing professionals in the post-acute long-term care settings. We're all here today because we want to make a difference please join me in championing those who dedicate themselves to caring for our frail elderly. Thank you.
Thank you, Ms. Stewart. We will now move on to Ms. Wiggins.
Good afternoon. Thanks so much for inviting me to be here with you this afternoon. Just a disclaimer, I am here not representing the 1199 union. I work with the Training and Employment Funds, which is governed equally by the union and also by industry leaders. So once again, my name is Faith Wiggins. I oversee the Training and Employment Funds work in the long-term care sector. And we are an umbrella organization that serves over 40,000 healthcare workers annually in education, training, and career ladder opportunities. We have about 1.5 million home care workers, nursing home workers, and hospital workers who have been trained to date in the history of our organization, providing a full range of educational benefits to the healthcare workforce. We address systemic barriers that affect low-income New Yorkers while also addressing healthcare labor force shortages. We introduce programming focused on placing trained workers in jobs while also addressing skill and labor market gaps and providing the training and education that's necessary to address diversity of the workforce. So with that said, our work includes access to higher education, skills training, and employment support. Just sort of looking at where we are in this presentation, many things have been said. I'm going to try to eliminate the things I have in my notes that are duplicative. But in terms of the training and employment funds, our workforce services really would not address our community without also looking at the wraparound support services that workers need. This includes worker benefits like healthcare, childcare, and educational supports that the 1199 labor union has aggressively bargained in their contracts with participating employers. So we were asked this afternoon to share what does quality in nursing homes mean to the folks in our groups? How can nursing homes better support the people in our group? And what would be one recommendation? So I will apologize in advance. I have more than one recommendation, but I think I'm coming into this space really thinking from the frontline workers, whether it's the CNA, the housekeeper in the nursing home, or the person who's providing food services. I'm really speaking from the worker's perspective. And in terms of what does quality look like, it looks like support that addresses some of the longstanding problems, many of which have already been presented and discussed, such as long-term standing problems like low wages and the race and health inequities that exist, also the hazardous conditions that workers often experience. And the recommendations are going to focus around both individual and collective action. Also, I'm glad that in this forum, you have space for workers to step forward and speak out, in addition to union voice and also different structures for ownership of long-term care facilities, such as worker ownership. I'm not going to do a deep dive in any of those, but those are among some of the recommendations. So we have an opportunity to seize the moment right now, given that even prior to the nursing home pandemic, there was a lot of attention on how we build support for reform, including looking at the staffing minimums. But now, given the terrible toll the pandemic has taken, with over 35,000 residents and almost 500 staff deaths reported in the United States, and I'm sure that number has grown since I pulled that. It's led to unprecedented attention on the industry. The New York Times alone had 60 articles about nursing homes in the first 6 months of 2020 versus 4 in the same period the prior year. So both state And federal legislators are paying attention to the industry and are willing to criticize it, but we have to really work to help come up with strategies to fix it. So again, I really appreciate this convening moving in that direction. So how can we finally fix some of the longstanding problems? We know that the industry is built on a financial model of understaffing and keeping workers at poverty wages. So at the core, that's something that needs to be addressed and fixed. Also, while I understand the push and pull in terms of regulatory mandates, while the pandemic hit high quality and low quality homes with equal force, we really can expand regulatory attention to include the long-standing problem of staffing, which one institution reported clocking just 2 hours and 20 minutes of direct care per resident. That's clearly not enough. So vacancy rates are rising, homes may not recover to full occupancy. The negative publicity will likely lead to more potential residents seeking alternatives to nursing home care. And meanwhile, owners are still making profits because of the, what someone used the word, dupes the state officials into thinking that they have razor thin margins, but in fact, many are charging themselves rent and management fees to appear to have lower profits than they actually do. So a lot of things to do, but at the core, the worker, the frontline low wage worker is most in jeopardy of this very broken system. And what does poverty look like for the working poor? It contributes to poor health. There are hazards that result, and it also influences just the feeling of what it means to be part of a workplace and a work community. So workers in low wage jobs get sick more often, die at younger ages. They also are more likely to experience chronic conditions, poor diet, nutrition, obesity, lack of physical activity, smoking, depression, and exposure to environmental pollutants. This creates a sense of marginalization and a feeling that they are second-class citizens, leading to low self-esteem, reduced job satisfaction relative to higher wage earners. And all of this is a stress ingredient, which is, we all know, is not healthy. So economic inequality, has all of these other impacts that with higher wages and better job standards could be fixed. This could increase access to adequate housing, to quality education, to medical care, and all the other things that are entrenched in this system of unequal care around living wage, which is a human right. So how do we move forward? Workers have to be part of the solution. Their voices need to be heard. And often when workers are speaking up, somehow management sometimes stigmatizes workers who are immigrants, many non-whites, people of lower socioeconomic backgrounds, and workers believe that sometimes their differences and different ethnicities are discriminated against simply because they can't carry themselves the same way that management does. Their words and phrasing and dispositions are different. So learning the cultural competencies to not degrade those differences, but to embrace them is a part of the solution. Some workers report that constantly conforming to a way of being to be accepted in the workplace is a stressor in and of itself, and often will be written up for things that others would not be disciplined for. And as a result, it leads to headaches, nausea, other conditions resulting from that stress. And in terms of other barriers, it's been very gendered work, as we know. So women choose these caregiving jobs and frequently are stereotyped in ways that discriminate, that are due to gender biases. So if you have a certain family size or you are absent due to caring for family members, or you become pregnant, these are things that are common practices still in discriminatory hiring and firing. So it's a lot. It's a lot of stress. It's a lot of things to deal with. And add on that the current racial climate and the various triggers that that causes, there's work to do. So what do we do? One is spend more on resident care and spend more on staffing. Shift that dynamic. The minimum, I've heard different numbers out here, but what the 1199 union is pushing for is at least 3.5 hours of care per resident per day. And raise wages. Wages must be living wages. And in New York City, $15 minimum wage is not enough for anyone, but raise wages. That'll improve and minimize the stress. Have new accountability measures for infection control, including requirements for worker participation in the planning and decision-making for that training. Also, planning to reshape the industry, including criteria for which when homes are going to close, that some of that capital should be used to create worker and resident-centered spaces in the workplace, and having new tools for accountability and oversight, including public notification of ownership changes and easy access to homes' financial information. So local employers have to really commit to setting goals for improving their diversity and reporting out to the public on the progress towards those goals. Job creation in targeted communities to rebuild high poverty neighborhoods, especially in this COVID recovery space, improving wages, work supports, job quality, and other things to help immigrants and people of color to advance. This means minimum wage, living wages, subsidized employment programs, paid family leave, paid sick leave, childcare assistance, fair scheduling, and renewed rights to organize and bargain collectively. All of these things will help to reduce some of the income and racial disparities and strengthen our economy. And in terms of worker ownership as an option to investors buying nursing homes, have workers be able to, and leaders be able to access financing tools to create new structures of ownership and participation in the long-term care sector. So these are some of the things and recommendations of workforce supports that will help shift the culture of the long-term care sector. Thank you.
Many thanks for your insights, Ms. Wiggins. Now we are going to move on to Drs. Nace and Steinberg.
Great, thank you. I'm Carl Steinberg. I've been a nursing home and hospice medical director since 25 years or more ago. I'm in Southern California. And if you go ahead and advance the slide. Dr. Nace and I are used to doing CMEs, but you can just skip this. We don't have any real conflicts of interest. It's really an honor for me to be here. This is a great group. I know a number of you and have worked with a number of you. And I can just say I'm very glad that the National Academy is taking a crack at this really complex topic. And, and I'm confident that you'll continue to seek the input of those of us who actually spend time and, have basically devoted our lives and our careers to caring for this precious and vulnerable group. We're advocates for the residents. We are not industry. This, I know many of you are familiar with our organization. I'll tell you a little bit about it. It used to be the American Medical Directors Association. We retained the acronym AMDA, but we don't. We've expanded our membership. We're the Society for Post-Acute and Long-Term Care Medicine. We've got about 5,000 members, mostly doctors. We represent medical directors, other docs, nurse practitioners, and PAs, and other people practicing in the post-acute and long-term care continuum. We've got a couple of seats at the AMA. We've pushed policy up through them, and we're very busy. We're a very active kind of grassroots volunteer organization. If you're not familiar with our clinical practice guidelines, please check it out on our website. We also have an affiliated organization, and I hope many of you are familiar with it. There's a certification for medical directors, a CMD certificate. There's a board of post-acute and long-term care medicine. And this is a credential that requires both 40 hours of intensive education specific to the nursing home setting, including the complex regulatory framework we work in, clinical with concentration on geriatrics. We see a lot of care in our buildings that is not really geriatric friendly, people coming out of the hospital and so on. And then also bioethics training. And then there's an experiential component. And I appreciate Beverly earlier talking about the importance of good medical leadership in facilities, because let's face it, we are taking care of medically ill and complex patients. There's also through our board and attending physician competencies coursework. So next slide, please. So what I was saying is we're not advocates per se, and we are certainly not industry, but I believe most of us on this call and throughout long-term care are after the same thing: high quality care. Our patients getting care in a community where they are respected, and that. And it's so easy to demonize, the industry as if it's one thing. And many of us who've spent a lot of time in these buildings can tell you that people's heart is in the right place. So I feel like that needs to be said, because it's so easy to have stories of abuse and so on. Anyway, so we've already talked, many people have talked about the sort of the custodial versus skilled, or post-acute versus long-term population. That is complex, and that's something your group should be thinking about. Should they all be lumped in there together? Really, should there be two different kinds of care settings? I don't know the answer to that. I can tell you it's easy to criticize a facility for wanting to evict somebody who's assaultive, some 45-year-old who's going around punching 90-year-old ladies. It's easy to say they should take them back no matter what. And I've been on the other side of that. So in any event, everybody deserves appropriate, ethical, competent, trauma-informed, and goal-concordant care. So, advanced care planning is important. And the industry may not always want a medical director who has those skills. So anything this committee can do to help push in that direction. We have not even been able to get CMS to compile a list of medical directors. I mean, if my mom was going into a facility, I'd want to know who the medical director was. So they don't want necessarily somebody who understands geriatrics, understands all the regs, and will advocate for the best interest of each resident. It's commonplace for them to hire somebody who's going to push admissions their way, keeps the heads in the beds. So we appreciate any help you could do in moving the needle away from that and towards high quality. Now I'll turn it over to my colleague, Dr. Dave NASEM. Thanks for having me.
All right, thank you, Carl. And my name is Dave NASEM. As Carl mentioned, I'm the current AMDA president and have worked with many of you on the committee and also on this call here presenting today. And just thanks for the opportunity again. So we're asked what the most important recommendation to make to the NASEM group that would impact the quality of care in the nursing homes. And the simple answer to that is we have to stop thinking that there's a single solution or a single recommendation. The fact of the matter is that there are many things that we need to address in order to improve the quality of care in long-term care. I'm reminded of Menken's comment that for every complex problem, there's an answer that's clear, simple, and absolutely wrong. And that would be the same thing if we thought that we could solve long-term care with a single recommendation. What we know is that we've had 35 years of the same approach, and the quality of care that we get right now is really the highly refined product of that same approach being tweaked over and over and over again. It really is time for us to make a difference and make a change. And as Beverly said, we really need bold action. We need a bold change at this point. Next slide. Some of the issues that we've talked about, and just to highlight that, I think what's really helpful here is to understand that everybody that's talked today has brought up valid points. We can agree or disagree on the extent of those and the relationships, but all of them are valid points. And that just underlines the complexity of the issues that we're facing. One of the ones that bothers me often, and Carl alluded to from the transitions of care point of view, is that we failed to consider, plan, and incorporate nursing home care or post-acute and long-term care into the larger healthcare system. The hospitals know there's a long-term care facility out there, and it's a discharge destination. But it's not thought of as, how do you bring that into the care plan for this particular person? And how do we ensure that the care that they get once they leave is going to be adequate for them? And have we provided them with the information in order to make sure that they take good care of the residents? We recognize, I hope, that there are differences in residents, and person-centered care is critical to the care of any individual, whether they're a nursing home resident or somebody who is living in the community. But we also fail to recognize that nursing homes are all different. They're not monolithic. There are some individuals and facilities that take care of highly complex rehab-based, ventilator-based care, and others that take care of primarily cognitively impaired individuals. And obviously the approach to those will need to be fundamentally different from a regulatory standpoint, as well as from staffing standpoints, and some of the other issues we'll talk about. The financing systems, and Eric talked about this very nicely, that they're quite cumbersome. They fail to account for the costs of care. It's not easy to see the transparency, as Robert had brought out, and they fail to account for the prevention of waste, fraud, and abuse. And there's a tremendous burden on the patients, the residents, and their families. Next slide. We have a costly regulatory approach that has failed to improve the quality of care. And it's easy to game this system, unfortunately. And we've seen that with many organizations who don't have the same goals of care that you and I might have. If you look at Deming's 14 points of quality improvement, many of the things that we look at from the regulatory approach here are fundamentally flawed. Mass inspection of facilities on an ongoing regular basis is not a fundamental quality improvement approach. And it does not work. It fails to adequately reward good performance for facilities, and it conflates, unfortunately, compliance with quality, and they are not the same. It judges all quality or compliance as all or nothing. So you can do the same task 100 times and unfortunately realize that on one occasion it's not there, and that leads to a significant problem from a regulatory standpoint. And it relies on blame and fails to drive out fear and doesn't take a systems approach. And that has been observed not by those working in this environment, but outside organizations like Doctors Without Borders. Next slide. Staffing challenges, the great pandemic. And in the interest of time, I see that we're coming very close to the end, so I will go quickly here. But this is a forgotten pandemic, the direct caregiver workforce shortage. We need to optimize nursing home staffing. And a single metric is not going to work. We have to understand what the composition of that staff is. Just like Lori pointed out, the activity staff for individuals with dementia and nurse aid staffing in those circumstances. And then also RN staffing and LPN staffing for very complex patients. The type of residents receiving the care, and then unit variations within the facility. So some units should probably have higher levels of staffing or different levels of staffing than others. Next slide. So our recommendations, would be to encourage access to engaged, competent medical directors and medical professionals. The training requirements that we've talked about that several states are looking at and already present in Maryland, incentivize access to quality and access of medical providers, and the registry of medical directors, as mentioned. We support a national commission that was already mentioned in the Coronavirus Commission to address the direct care worker shortage. And we think that is really critical. We're right. We need more caregivers. They need to be paid a living wage. And this really has to be addressed, not just for nursing homes, but all care, including home and community-based. And we need to support research around the best models of care to optimize staffing. Last slide. So we also need to reform the regulatory process, not get rid of regulations, but align it with principles of patient safety and total quality management. And then there's the issues of inequity in care based on geographic region, racial, ethnic, and social economic differences, and those are critical. And then the financing system, as we already mentioned, to access or allow access for the care needs of all patients, including those with cognitive impairments, the non-institutional care whenever possible, to cover the costs and ensure, particularly around rural America, and the access to good quality long-term care there. And next slide. And that should take it to the end. So just thank you to the group here for the invitation to present today. This is obviously of critical importance. It's a high priority to ensure that we provide the best quality of care possible and the best quality of life possible for the residents of our long-term care facilities, which are our friends, our acquaintances, our family members, and ultimately will be us. Thank you.
Thank you, Drs. Nace and Steinberg. Lastly, we have Dr. Scales, who will finish.
Thank you very much. Thank you. Thank you for the opportunity to present today, along with such an auspicious group of experts. Next slide, please. I am the policy director for PHI. We are a national nonprofit organization. We do research, consulting, and advocacy, and all of our work is focused on improving the quality of care for older adults and people with disabilities by improving the quality of jobs for those that provide that care, namely direct care workers, who include nursing assistants in nursing homes, who are the focus of my remarks today. And I'll start out right away by saying that a lot of what I'm going to say really echoes and emphasizes what we have already heard today. And I think that that just speaks to the importance of these issues, which cannot be overstated. Next slide, please. So I do want to begin by taking a step back and offering just a brief snapshot of nursing assistants in nursing homes and the challenges that they face. Next slide, please. This is a workforce of about 566,000 nursing assistants working in nursing homes across the country. And they're just one segment, about 12% of the 4.6 million strong direct care workforce that works across settings, particularly on the long-term care continuum. So we heard already that it's important to think about these workers as part of a bigger workforce that we are raising standards for. The nursing assistant workforce is predominantly female and people of color, and about 1 in 5 nursing assistants is an immigrant. And these are the staff in nursing homes, as we've heard, that provide the majority of direct hands-on care for residents. Currently, they provide an average of 2.1 hours of care per resident day, compared to about 0.8 hours for LPNs and 0.4 hours for registered nurses. And our analyses indicate that they support on average 13 residents per shift, but at least 10% of nursing assistants support 16 or more residents per shift. And we've already heard today about supporting 24, 25 or more residents as well. These analyses, of course, are from before the pandemic and the extra pressure that we have seen. Next slide, please. I just want to offer one quote directly from a direct care worker at a facility in Georgia who's participating in our direct care worker story project. She says, she describes her role thus. She says, you have a lot of responsibility taking care of members, meaning residents. You're giving medication, you're doing laundry, you're feeding them, you're giving them a shower, you're making sure they don't fall. You are also taking care of their family members and answering all their questions about their loved ones. We are the eyes and ears for these members, and we know what is going on with them 24/7, more than anybody else. And that absolutely, I think, illustrates the complex nature of the nursing assistant role. It is technical, but it's also relational. It's about observation and communication just as much as it's about hands-on assistance. Next slide, please. So very briefly, these are some of the long-standing and very well-documented challenges facing this workforce. First of all, this is a low-wage occupation. Median wage per hour is $13.90, and that translates into low annual earnings of just about $23,000 a year. As a result, more than 40% of the nursing assistant workforce lives in or near poverty, and more than a third require or rely on public assistance to make ends meet. In addition, these are entry-level roles with limited training expectations. The federal minimum of 75 hours hasn't been revised for decades. Training content tends to be fairly traditional and didactic rather than evidence-based and adult learner-centered. And once you're in this role, there are very few career pathways as a nursing assistant, except for the leap up into licensed and registered professional positions. We also know that these workers, nursing assistants, direct care workers, are 35% more likely than all US workers to hold second jobs, again, to make ends meet. And that's something, the implications of that have become particularly clear during the pandemic and the risk of community transmission. And nursing assistants are 3 times more likely to experience on-the-job injuries than all other US workers. Again, that was pre-pandemic. Now we're talking about these jobs as the most dangerous jobs in America. Next slide, please. So just briefly to speak to that, because I think we have to, we know that nearly 600,000 nursing home staff, predominantly nursing assistants again, have had COVID-19 suspected or confirmed. And that translates into such greater pressure on a workforce that was already strained. So 1 in 5 nursing homes are now experiencing and reporting a shortage of nursing assistants. And yet we're still not in a position to fully protect these workers and the residents that they care for, as more than 10% of nursing homes are reporting that they still have a shortage of at least one form of PPE. Next slide, please. So I want to offer 2 overarching recommendations for action. The first is to consider the quality of jobs in nursing homes as indivisible from the quality of care in nursing homes. We cannot have one without the other. And the second is to consider job quality as a multifaceted concept, as you see here. This is a framework that PHI offers for considering direct care job quality in terms of 5 pillars: quality training, fair compensation, quality supervision and support, respect and recognition, and real opportunity. And the idea is that we need to make progress across all of these domains in order to improve recruitment and retention, to stabilize and also to better leverage this workforce, and ultimately to improve clinical outcomes and quality of care overall. So I'm just going to quickly offer some more specific recommendations across these domains, beginning with quality training. It's time to establish a national standard for direct care competencies that are relevant to all direct care workers, with additional competencies layered on top for population served and for setting, such as skilled nursing. There's been a lot of work done already to identify core competencies for direct care. We just need to take that forward and actualize it so that we can create a more universally qualified and flexible workforce that can be deployed as and where needed. For example, during a time of national emergency like the pandemic that we are in now. Next slide, please. I'm sorry, 2 slides ahead now. To get to fair compensation, we need to work toward making the nursing assistant role a viable career choice by making sure that wages are sufficient to pay the bills. That means establishing a wage floor for nursing assistants that aligns with the complex skills that they are now required to bring to this work, and that ties to the cost of living in their geographic area. For example, New York City was mentioned earlier. The cost of living is much higher than a $15 an hour wage can meet in that area. And we do need to ensure that wage measures are, and I will qualify what it says here on the slide, wage measures must be matched by reimbursement rates in a transparent process. So it may not be that reimbursement rates need increasing across the board, but we need to make sure that the money is being passed through, including through employer accountability, that it's being passed through to workers themselves in their wages and benefits. Next slide, please. in terms of quality supervision and support, there is a lot that we can do at the practice level to strengthen supervision and support on the job. At the policy level, I want to reinforce what we've already heard today, the importance of working toward evidence-based minimum staffing standards for nursing homes to improve resident to staff ratios, to improve the staffing mix, and to reduce the very real risks of injury, burnout, and inadequate care. Next slide, please. In terms of respect and recognition, there are so many different ways that we can tackle this, but one thing that we really need to do is recognize and take steps to address the structural inequities that are faced especially by people of color in this workforce, even within a workforce that's already marginalized. And there's sort of two strategies here that go hand in hand that are really important. One is to develop targeted interventions to address disparities within the workforce. And the other is to collect workforce data and disaggregate it by race and ethnicity and gender and other characteristics to identify where those disparities are, to evaluate our interventions, and to track changes over time. Next slide, please. The final pillar is real opportunity, and our real opportunity here is to develop, test, and scale up advanced roles for nursing assistants in nursing homes. This is a way to keep strong, committed nursing assistants in the workforce, and it's also a way to expand our capacity to provide high-quality care for residents by having, for example, dementia care specialists who are advanced direct care workers, advanced nursing aides, who have particular expertise in leading and implementing non-pharmacological direct care interventions, or care transition aides who are senior nursing assistants who can help specifically focus on breaking the cycle of rehospitalization. And the testing part is so important here because we need to be able to build the return on investment case for investing in training and more compensation for these advanced roles. Next and final slide to close out with, I would just like to end my remarks by directing the committee's and webinar participants' attention to the PHI website, where we provide a searchable database of resources on this workforce, a whole range of analyses and reports, our worker stories project that I mentioned earlier, and much more. Thank you so much for your time and attention.
Thank you, Dr. Scales, and thank you to all of our panelists today. You have really left us with a lot to think about, and your moving remarks have been profound. So right now we will transition into a Q&A session. Our committee has the opportunity to answer questions. Just please use the raise hand chat function. And first, I will call on Dr. Marilyn Rance.
Thank you, and thank you to the panelists. We appreciate your expertise and your comments. They've been quite thought-provoking. I have two follow-up questions. One is about the APRN role in nursing homes. As you've talked about the worker roles, I've been surprised this morning or this afternoon at the lack of comments about the potential benefits of the APRN role in nursing homes. So I wondered about that. That's my first question. My second question is about, tell me more, or tell us more about the worker ownership model and where you have specifically seen that work well or successfully in the country. Those are my two questions, the worker ownership and then the role of the APRN in nursing homes.
I can start. It's Carl Steinberg. I would say, nurse practitioners, other advanced practice nurses have taken on an increasing role over the last 10 to 15 years in the post-acute and long-term care setting. They are invaluable. Our, AMDA made nurse practitioners full voting members, I don't know, maybe 5, 6, 7, 8 years ago, something like that. And they're more than welcome. And many facilities and chains have sort of embedded nurse practitioners in facilities. And I think there's strong evidence that having them there, at least in the post-acute population, can help prevent a change of condition that's severe enough to create a rehospitalization and that sort of thing. So we're strongly supportive of it and feel that anything that can be done to have good, competent geriatric care on site is a plus.
Yeah, I'll just add to that. I think that the CMMI projects, Centers for Medicare and Medicaid Innovations projects, if you look at those, University of Pittsburgh had one of those, one of the 7. And if you look at the ones that were very successful, they had advanced practice nurses who were a core intervention within these facilities. And so there's plenty of data to say that that access to care is really enhanced, and that prevents readmissions. It improves the quality of life, end of life care, compliance with clinical practice guidelines. So really are major interventions into improving care.
If I could just add one thing to Dr. Steinberg and Dr. Nays. When we look at the way that the employees are made up in the nursing home, the APNs are often working with the physician groups. And I just mentioned that because, you know, again, as I mentioned in my comments, we find it hard to attract more than associate degree nurses. In fact, master's prepared nurses are rather rare, but we certainly support the research that shows having an APN in the building on a daily basis decreases rehospitalizations by leaps and bounds. I mean, you can't deny that, the research.
I'd like to speak to the cooperative or the worker-owned question from Dr. Rance. My organization, PHI, was actually formed in the early 1990s as the nonprofit development arm of Cooperative Home Care Associates, which is a worker-owned home care agency based in the Bronx that's been in operation since 1985. And in fact, it's the largest cooperative worker-owned organization of any type in the country. So it's a really, and we continue to work very closely with them in developing and implementing workforce interventions and innovations. And it's a wonderful place to see how these efforts play out and what the successes are and what the challenges are. I would say that the absolutely clear benefit of the cooperative or the worker-owned model is that it places the workers that we've been talking about at the center of everything. It's about ensuring that workers' salaries, their compensation is part of all of the financing decisions within the organization. It's about ensuring that workers are involved in making decisions that are appropriate to their role and having ownership, literally, but also figuratively, of the work that's done and being very engaged. There are also a lot of challenges associated with pursuing this model. It requires a lot of capacity on the part of the organization to develop governance, appropriate governance structures and so forth. But what we have definitely learned is that there's so much to take from the worker ownership model and apply in other settings, even if they don't actually follow that ownership model. So that idea of putting the workers first, that idea of promoting from within whenever possible to ensure career pathways for workers, the idea of making sure that there are clear structured opportunities for workers to be involved in care planning, but also decision making around the organization itself and so forth. So I think there's a lot to learn from that model, even if it can't be adopted or upscaled to a massive extent.
If I could chime in, I don't know if there's a cue. I'll pause.
Please.
Okay, great.
Go ahead.
So thank you, Kezia, for that update. And just, I was one of the founding staff and board members of PHI and worked at Cooperative Home Care Associates that Kezia referenced for a little over 9 years, part of my journey into the long-term care space. And the 1199 labor union is actively engaged in the process of exploring in many different areas the expansion of worker ownership as a union building and economic sort of empowerment agenda in the long-term care space. So there was work done with the UCLA Labor Center that articulates how a co-op framework can really help to build rights for independent contractors and other workers. And actually PHI was consulted by an organization that is union affiliated in the Buffalo region, Healthcare Workers Rising, to look at various forms of cooperatives, including transportation. One of the problems in Northern New York is that not only are workers having difficulty getting to work, whether it's a nursing home or a home care agency, they also, can't find adequate transportation support. So given all of the linkages between transportation and work quality, they're also exploring the possibility of forming a car service co-op, so that for part-time employment, which is one of the barriers in terms of job quality, it could be a way to leverage jobs by both being a driver, helping other workers get to work when you're not working, and hopefully bring about full-time wages, since having full-time wages in the long-term care sector for some people in the workplace is a real challenge. Many jobs are labeled as part-time, and workers get pulled in sometimes for overtime and other work, but aren't coming with the full benefits of a full-time job. So worker cooperatives is another way, as Kezia said, to bring in worker voice and build worker leaders and have that engagement between the persons providing the care and the service, and with management, because workers are the owners and are responsible for forming the principles and values of the organization. So it is a really active strategy on the labor union side to help build equity in the workplace.
Thank you. Dr. Philip Sloan.
Thank you to the group. This has been a very incredible constellation of individuals with very helpful comments. Now I'm thinking about what I've heard about the hierarchical management structure and the failure of leadership to include direct care workers. And I'm wondering, I haven't heard anything about quality of leadership or training of leadership or administrative leadership. And I just wondered, have any thoughts about how to improve that and standardize it so that the quality is excellent across settings?
Hi. I mentioned in one of my recommendations the need for leadership training across the board to build strong leaders, transparent leaders, leaders with good communication. And I think what I'm seeing, especially during the pandemic, is facilities or organizations with really strong, transparent, good communicating leaders are getting ahead of this and not seeing some of the issues with turnover that you see in facilities who don't have that strong leadership presence. So I would say that we definitely need to have leadership, but not just your basic leadership training. It has to go beyond, just how to lead during a crisis or how to lead in this situation or that situation, but how to be a true leader, especially for the director of nursing role. And I say that because that's often a role that I see as the nurse who is the CNO of that building, right? She's the chief, he or she is the chief nursing officer, and often not treated as such. So I think that the leadership training would help them and elevate them and make them even feel better about their role as well.
Yeah, I think I would say that, we talked about the role of the medical director and having engagement of the medical director. What we've learned from our work on COVID and a public-private partnership here in Western Pennsylvania with the Department of Human Services and Department of Health is that the COVID outbreaks, when there is an engaged medical presence, And that's the medical director and or nurse practitioners and physician assistants and attending physicians. There are far better outcomes. And if people really utilize leadership skills, not just management, but also the leadership skills, we are seeing far better outcomes. And all the work that we've done in research projects, the improving outcomes of UTI management that we did, that I know a few of you are familiar with, we saw that when there is an engaged person who takes leadership and knows how to interact with others. We've done a training program here in Pittsburgh called the 3Ps program a number of years ago, where we had the medical director, administrator, and director of nursing sit down together. And the thing that we heard over 8 years of doing this, everybody wanted it to continue, everybody enjoyed it. But the thing that was most frightening that I heard every single year was, this is great. This is the first time I've sat down with my medical director. And to me, that was one of the most striking and condemning comments about leadership within a facility. If you are not communicating as the leaders within that facility and interacting, it's no wonder we don't get good outcomes. So that really is critical. Knowing how to be able to build teams, knowing how to go through all the leadership concepts, organizational culture, that it's critical and essential, and we certainly support that as an organization.
David, that was such, Keezy and I, with our PHI connection, and David, you mentioned the 3Ps. There was a program many years ago that Peggy Powell, who's at PHI and, some of us at Cooperative Home Care developed, called the 4Ps. I wonder if it's related. It was sort of like pull back, pause, paraphrase. It was a communication tool that really helped people engage. On the union side, just to the question of how do you get to worker and management sort of collaboration and input and exchange, the model of having ongoing committees that might have actual goals where workers are engaged with supervisors and administrators working together to make improvements. So standing committees that might be looking at, how to at inventory and how to save on purchases, or looking at jobs. There are jobs committees where if there are vacancies, and there are, a handful of people who want full-time work but have part-time shifts, then look at scheduling practices that might lead to better job quality. But when you have workers at the table in an ongoing way and their voice is welcomed into what might typically be management practices, there's just a lot of ancillary benefits to that. So just wanted to throw that out there as one suggestion.
Hi, Dr. Sloan. I just wanted to jump in as well. It's a really good question because it clearly can be addressed on so many different levels. And I just wanted to speak real briefly to the importance of the mid-level management and leadership, and what we know about the importance of direct supervision for keeping people in their roles. The quality of supervision makes a difference for whether people last the first week or not, the first month or not, and so forth. And also for ensuring that they are equipped to do their best job. And so I think along with direct care competencies, we need clearly identified direct care supervisor competencies, because supervisors are so often promoted into their roles because of their clinical expertise and not necessarily with any preparation to be good supervisors. So we need those competencies, and we need good training based on those competencies to ensure that our mid-level managers are actually prepared to support quality care at the front line.
Thank you. So we have a question from Dr. Gregory Alexander. We'll probably wait for him to be.
He's currently unmuted.
Okay.
Oh, sorry, I was muted on my phone and my computer. So can you hear me now?
Yes.
Great. Okay. Thank you all so much for your time and for your thoughtful comments. So I have a question, and it's related to a comment that was made about one of the challenges about failure to integrate nursing home care. And so out of our committee, I'm sort of the informatics expert, and I work a lot with technology in nursing homes. And over the two committees that I've sat through today and listened, I've not heard technology mentioned. I think that from my purview, technology is a critical component that's been those innovations have come forward since the 80s when the last report was given. And I think that the lack of technology in nursing homes has created a sort of a gap between what happens in other healthcare environments and long-term care. And I was surprised to not hear anything about that significant change in the way we deliver care. And I was wondering if others would maybe comment on that, if that is something that is important, is something that we should look at and think about, and how so?
I could start. Thanks for that. And maybe that was an oversight. It's certainly a significant issue, particularly with respect to the post-acute population, where somebody comes into the facility with still either faxed or maybe through some eSIN or some other system with a couple of pages, the history and physical and that sort of thing. And if the admitting doctor and the admitting nurses don't have access to the hospital's EHR system, there can be a significant gap. And we're still doing faxes. I mean, we still get lab reports by faxes. So, I guess personally, I was just assuming your committee would be addressing those issues and making those recommendations. We in the nursing home sector didn't have the push that, let's say, doctors' offices and hospitals did, with the big bonus for adopting EHRs. I think it's incrementally moving in the right direction, but it's bad. I mean, the EHR systems, I don't want to call anybody out, but let's just say they are suboptimal right now.
Ms. Wiggins?
Yes, thank you. So in to address that point, we have done a lot of training in terms of general computer skills and just sort of other work to build really the basics, because we have found that nursing home workers really are at the low end in terms of digital equity. Many don't have access to Wi-Fi at home. Many do not have computers or laptops. And given the age of the workforce, many are using phones that do not have internet access. So it's been a real challenge given the spread of the workforce in terms of where they are with their skills. If you're speaking on the clinical side, it's a little different, but for frontline workers, we think there are a lot of opportunities. There are many tools that are being used, but part of the problem is it's not universal. So if someone is moving from job A from nursing home A to nursing home B, they're not necessarily carrying portable skills if they were trained in a certain technology and software at job A that they can carry forward to job B. So I think that it is on the minds of both workers and managers. I think having the resources to really build and develop those skills is also a challenge, because given the low staffing rates, when can workers actually train on the technology and be able to use the technology, and building it in at the entry level does not necessarily make sense, again, because the tools that are being used are not uniform from place to place. But it is something that I'm hearing a lot about, and in terms of our training fund and the things that we're able to reach, we are trying to build just the basic competencies and awareness in terms of tech and use of computers and phones and other smart devices.
Thank you. Ms. Stewart?
Hi, Dr. Alexander. I had put as one of my final recommendation was to address funding for technology. And one reasons I mentioned that is because larger organizations have more access to technology in many cases, but even then, they might have an EHR, and there's a number of EHRs out there that have a lot of extras. I think to Ms. Wiggins' point, you go to one facility, you have a certain EHR, and then you go to another facility and they have a lot of those items are actually turned off because they can't afford, to have that. And the other, and it goes beyond just the applications. It also applies to user-defined assessments. For some facilities, they're putting it in themselves instead of using the evidence-based UDAs that come with a EHR because it's cost prohibitive.
Thank you. Dr. Nace.
Yeah, and thank you for asking about IT here, because I think it was an oversight on our part too, not to bring it up. Again, so many things to think about, but there is the issue of interoperability and information transfer between the hospital and the long-term care setting, and that's particularly problemsome, so that the hospital may not know what is actually happening in the long-term care setting. Even though we send records with the person in the ambulance, we know very clearly that the paramedics are taking those records and selling them on eBay because they never get to the hospital, it seems. It just is one of those things we see all the time, and the information's lost. If they had access to the electronic record and could see what we were looking at, they could see and avoid duplicating a lot of the stuff that was done in the home already. There's also the issue that these EHR systems are not meaningful use certified for the physician. So we can't get data in terms of risk adjustment for physician practices and for practice styles, and to identify, best practices and quality improvement, based on how somebody is actually, seeing a patient and what kind of processes they're going through in terms of the actual clinical care. So that's another issue. And it's just frustrating to see that, my portion of the chart is a text box and a cursor, and that is not operable. So.
Thank you, Dr. Scales.
Yes, just add one further comment about this. There's so much that we could say about technology. Just in thinking about the very frontline direct care workforce in nursing homes, one thing that I witnessed, I have done a lot of research where I was serving as a CNA to do ethnographic research. And what I saw was that the technological interface that was brought in for CNAs to try to capture that 24/7 knowledge that they have was maybe not, to repurpose the phrase, meaningfully used, because it wasn't well enough integrated into their workflow, and the purpose of it wasn't clearly enough communicated and manifested. So they kind of went through the motions of filling out point of care sort of documentation, but never learned about where that went or what it meant for resident care and for the value of their own contribution. So I just want to make that plug again for connecting these kind of solutions to the broader picture of quality jobs and meaningful participation.
Thank you, Dr. Scales. Do we have one more time for one more question? I know Dr. Christine Mueller has been waiting to ask a question.
Yes, let's take one more question.
Thank you.
Thank you, Jasmine. And thank you to all of you this has been such a great session. So my question might be too big for the remaining time, but it goes back to regulation, particularly in the first panel. You addressed it quite a bit as a lever, regulation being a lever to address quality, and seemed to be a lot of enthusiasm for the necessity of regulation. I think it might have been you, Lori, who said, the question isn't about more or less, it's more about purpose. And then later on, Dr. Nace, you talked about, I think it was you, modernizing the approach that we might use for regulation. So as a committee member and this group that's likely going to want to address a recommendation around regulation, what are your perspectives on any kind of recommendations we would consider for using regulation as a lever for improving quality in nursing homes.
Well, I'll just say that, I think the issue around regulation is that they're complex, they're exhaustive. Having read these regulations in and out over and over again, having to try to memorize the federal F tags as they've been changed over time, it's daunting. And there's a lot of myth and mysticism around the regulations, where people will bring stuff up and say, look, we can't do this. This is a regulation. And when you ask them to actually pull that regulation and show it to you, they can't. When I started in long-term care, I started with this this fundamental thing. When somebody quoted a regulation, I made them produce it because I found that a lot of times things were regulation, which were not really regulation. And so there's a lot of confusion, and it's because it's comprehensive and it's hard to stay up with these regulations. The other thing is, with the regulatory approach, we do spend a vast amount of time inspecting every single home, every single year, multiple times a year. And there are clearly facilities that probably need to be focused on much more heavily. If we notice that there's a problem around quality of life or quality of care within a facility around a specific area, it would probably be best if we had ongoing regular analysis of those facilities to make sure that it's been corrected, to make sure that the deficiencies have been addressed. But we put everybody through the same process. And as a result of it, that's one of the things that leads to that feeling of blame and that feeling of just being beaten down, that you're being pushed through a lot of stuff that really doesn't necessarily make sense. We've had situations where somebody came in and complained about thickened liquids. There was a complaint survey related to it. The surveyor came in and reviewed the documentation, talked to the nursing staff. How did you mix it? How did you do this? The person walked in and picked up the cup and swirled it and said, I don't think it's thick enough. It was absolutely thick enough because it was the exact measurements according to the packages of how to mix that. And so that is the type of thing. There's interpretation, but not just the staff, but also from the survey agencies. There's a lot of room for judgment, and being able to standardize it is very difficult. It should be really driven, as Lori said, it really should be driven towards quality improvement. Is a facility actually doing quality improvement? Are they actually tackling things and addressing those? And when you address those, you shouldn't be punished for addressing it. You should be encouraged and pushed. Medication error reporting. We shouldn't punish for medication errors. We should punish for not finding them, because we know medication errors occur every single day in every single healthcare facility in this country, multiple times. So we should encourage detection of them, because when you find those near misses, you prevent the fatal accidents. So the more we find medication errors, the more we find problems with quality, the more likely we are to identify issues that need to be corrected and adjusted. So.
Since
Thank
I
you.
was referred to, could I have just one moment?
Sure, we'll have one more comment from Lori, and then in the interest of time, I'll just remind everyone that we really want to continue to hear from you. And so if you've not had a chance to respond to this or other questions, please do that through our website. But we'll have Lori be the last comment.
Thanks so much. I think, I stand by what I said in terms of saying, we need to have the regulations be meaningful and be implemented and have good oversight of them being put into place. I think that the regulations were put into place for a purpose, and none of them were just established and created just to give the facilities something more to do. They all serve a particular purpose, and I think that the result is that needing to to ensure that the regulations are being followed and that they're being implemented, and that it's providing moving us towards providing better care for residents, because unfortunately, you know, these are minimum standards, and the many in the provider industry have not taken it upon themselves to police themselves. And so that's really why we have, you know, the regulations and why they're really important. So, you know, I think that it really does go back to that. And there is a, you know, the other thing I know that we know for sure, and why we are so adamant that there needs to be ongoing oversight of these facilities on an ongoing and regular basis, is conditions change very, very quickly in long-term care facilities. We have seen that, and my example of multiple administrators in a year, multiple directors of nursing, that can make a huge difference in the quality of care that a resident receives. And it's important for the surveyors to be going in on at least an annual basis, because so many residents, family members can't or won't complain or share the problems that they're experiencing themselves. And so we need this entity, the surveyors, going in and assessing compliance for those people that aren't able to complain on behalf of themselves. So thank you so much for the opportunity.
Thank you, Lori. There couldn't have been a better last comment than reminding us that we're here to advocate for people who can't advocate for themselves. So thank you for that. I want to thank this last panel and Dr. Travers for helping to moderate it. Also, just a reminder that this entire webinar has been recorded and will be available on the link on the screen. And again, I can't emphasize enough how much we welcome anyone to submit resident, family, nursing home staff experiences and input. We really invite you. Please help us. And also encourage you to register for our next webinar. I'll just conclude today by saying that all of us on this call, the sponsors, the national academies, the committee, our speakers, our public, particularly the voices of residents and families, we're all committed to the same thing, and that is there has not been anyone today who says change is not necessary. We're all committed to improving the quality of care. And today has been a very important step to move us toward that goal. So we thank you all for your commitment and to help us to achieve this goal. We as a committee are very optimistic that we can make a big difference in the quality of life of residents and families. Thank you so much.